Hi everyone, a very warm welcome to all of you guys. Myself, Dr. Vaibhav Jain, and in today's video, we are going to learn about the anesthesia. We are going to cover anesthesia in a very quick and concise manner. Okay, so before starting, please give me a quick confirmation whether I'm clearly audible and visible so that we can proceed with the session, guys. Good evening, good evening. Now I can see. Yes, we are visible. Okay, Monali. Okay, doctor. So, I think we should proceed with the session. So, today's session, what we are going to do, since exam is so near, guys, we are going to make it very crisp and concise, right? I have incorporated all the 5-year questions that has been asked in your FMG, NEET PG, and your INI set examination. So, you need not to worry about anything else. Okay, everything is incorporated. Along with that, theory explanation is also there. Okay, so be with me till the end of the session and feel free about anesthesia. Okay, so what would be our scheme of class? We will be starting as usual. We will be having a systematic class. So we will be starting it off with the introduction. I will be telling you about some points, important points about anesthesia. What are different types of anesthesias that we are having? Then we will be studying about the pre-anesthetic checkup. So it is going to be in the form of a story, and all the questions are just after the chapter, right? We will be having intubation, how to do intubation, different monitors that are present in your OPD, in your OTs. Okay, then we will be discussing about the anesthesia machine, anesthesia circuit, how many types of circuits do we have, and then we will be discussing about your anesthesia agents, ultimately oxygen therapy, some fluids, and we will end up this session with some miscellaneous topics, right? So without any further delay, I think we should get started now. Okay, these are my Instagram and Telegram. In case if you want to connect with me for any kind of doubts and any kind of queries, you can always get back to me. Okay. All right, guys. Should we start? Okay. So first slide. First slide. Can you appreciate who is this gentleman? Some questions are coming from the history itself. Okay. So who is this gentleman? This is your WTG Morton. What I want you guys to do, try to speak wherever you are sitting, try to speak and try to answer, because these are the types of question you will be getting. From anesthesia, you will be getting approximately 5 to 6 questions, but they are important. You can get all of them correct. Yes, this is your WTG Morton. This is your WTG Morton, and he is also considered as the father of anesthesia. He is also considered as the father of anesthesia. Okay, he is the father of anesthesia. Remember, guys, the term anesthesia was given by Oliver Wendell Holmes. The term anesthesia was given by Oliver Wendell Holmes. Okay, apart from that, when do we celebrate our World Anesthesia Day? Yes, Morton is the modern father, right? When do we celebrate World Anesthesia Day, guys? World Anesthesia Day will be celebrated on 16th of October 1846. Okay, 16th of October was the day. Okay. Yes, I will be telling you about the important things. We are just taking the startup. Okay, don't worry about anything. In 2.5 hours, I will be completing your whole anesthesia. Okay, don't worry about that. Just be with me. So, who is this gentleman? This is known as John Snow. He is also considered as the father of epidemiology. He is also considered as the father of epidemiology. Okay, about these scientists, they are your Edmund. This is your Edmund Gaskin Boyle. This is your Edmund Gaskin Boyle. What he has done, he has given the Boyle's machine. He has given the Boyle's machine or Boyle's apparatus. One more scientist you have to remember. These are the 5 you have to remember. One more scientist that you have to remember is about the August Bayer, and he is given a block that is known as Bayer's block. Bayer's block. Okay, he has given the Bayer's block. Okay, very good, Monali. Okay, now we will be discussing about the different types of anesthesia. Anesthesia कितने तरीके का होता है? That is what we are going to see. We are having, बच्चों, we are having general anesthesia. In general, it is of 2 types. We are having inhalational. It is Second one is your IV agents. We are having two things. One is inhalational, another one is IV agents. Okay. Second we are having regional anesthesia. Regional anesthesia, how we can achieve? Look here. General, the complete body will be anesthetized. Okay. In regional, we are having spinal, we are having epidural, we are having peripheral. Okay, we are having spinal, we are having epidural, we are having peripheral. Okay, so how we will utilize this information? It can be central neuraxial blockade, means if it is blocking in the center, that is central neuraxial blockade. What are the things that will come in this? We are having spinal anesthesia, that would be given in the spine, right? Second one is your epidural anesthesia. Okay, and third one we are having is caudal anesthesia. Caudal anesthesia. Three we have to remember: spinal, epidural, and caudal. Okay, second one we are having is peripheral neuraxial blockade. Peripheral neuraxial blockade means it will be blocking the it will be blocking in the periphery. So we are having, first one is your sciatic block. Second one is your femoral block. I can give a femoral block. Okay, I can also give, I can block the brachial plexus as well. So that is your brachial block. Okay, apart from that, we are having local anesthesia. Okay, local anesthesia will be having two things. One is infiltration, and second one is your topical. Okay, so try to understand how many types of anesthesia do we have. We are having general anesthesia. General means complete body is getting anesthetized. Okay, second one we are having spinal, epidural, and peripheral. Okay, these are considered as regional anesthesia. Spinal will be that we will be discussing how we are giving spinal and epidural. So that will be given below the waist. Okay, then we are having peripheral, that is for the periphery, and then we are having local anesthesia for local procedures. There is a question they will ask you for the dental procedure. Infiltration means what? They will be putting the anesthesia all around the tissue. Okay, topical, that you already know about the skin. Okay, that would be the different types of anesthesia. Okay, that would be different types of anesthesia. I will be telling you all the doubts. I will be taking all the doubts in the end. We will be discussing about these things first. Okay, so when we will discuss, I will be explaining you. Okay, so now we will be discussing about the pre-anesthetic evaluation. So try to understand what will happen whenever a patient is coming to you. Whenever a patient is coming to you, for example, there is a patient who is coming to you for like cholecystectomy. He is having some problems, and he is coming to you for some kind of surgery, right? So now what you will do? You will directly do not operate the patient. What you will do? You will send the patient to anesthesia department first, and anesthesia department, what they will do? They will do a thing that is known as pre-anesthetic evaluation. Okay, they will be taking the history. They will be asking the name, age, and sex of the patient. Why they are asking name, age, and sex? The reason being, name will be telling us about the eating habits maybe. Okay, age, there are some diseases which are more common in females as compared to males. Okay, and sex is also telling us about the male and female, and age is also telling us about the age criteria. Okay, some diseases are more common in older age group, and some diseases are more common in younger age group. Okay, then we will be discussing about the drug allergy history, whether the patient is having any kind of allergy. Okay, we will be discussing about the medication history, surgical history, past surgical exposure, okay, and past anesthesia exposure. This is the form of pre-AC, that is the form of pre-anesthetic checkup. Okay, now second thing that they will do is your general physical examination. They will be looking for your pulse, your BP, your cyanosis, pallor. Is there any problem on the physical examination? So that is your general physical examination. Okay, then they will be going for systemic examination. They will be looking for certain systems, like they will be checking for CVS, respiratory system, CNS, GIT, because there are some drugs. Why? Because there are some drugs that will be having particular effect on, for example, excretory system, or for example your hepatobiliary system. Okay, so that is why they are doing the systemic examination. Lastly, they will be doing some kind of investigations, for example like CBC, electrolytes, urea, creatinine. They will be telling us about the different organ situation. Okay, but the most important as far as anesthesia is concerned is all about the airway evaluation. Okay, so airway evaluation is the most important thing, most important step that you have to remember here. Okay, so what are the things that we will be doing? For example, a patient is coming to you for some kind of surgery, you will be sending the patient to pre-anesthetic checkup. They will be doing this particular checkup. They will be checking for history, physical, systemic investigations, and all those airway evaluation. And what they will do, they will send the patient for surgery again. Okay, they will tell the patient multiple things and then they will send the patient for surgery. Okay, so try to answer this question. Try to answer this question. Question number 1. Try to answer this question, guys. How is the pre-operative evaluation of the oral cavity conducted in adult to facilitate endotracheal intubation? Try to answer this. What the question wants to know, they wants to know about the how do we assess the oral cavity, and these are all previous year questions, guys. These are all previous year questions. Okay, so how will you will assess the oral cavity? With the help of which score? Are you going to check AHA grading? No, it is for the heart. It is for the heart. That is American Heart Association. That is for the heart. You will be studying in medicine. Okay, ASA grading. ASA grading, we will be discussing about it. That is American Society of Anesthesiologists. Okay, third one is your Conmack-Lehan grading. That is the laryngoscopic. That is the laryngoscopic view of glottic opening. That is the laryngoscopic view of glottic opening, right? So it cannot be the answer. The answer will be A. The answer will be A. Very good, Anuj, Anjali, carpal tunnel. Okay, that is the Mallampati score. Okay, so now one by one we will be discussing about all the scores that we are having. Okay, first of all, the important ones I would be telling you. The question is coming from this particular ASA grading. What is the meaning of ASA grading, guys? The meaning will be, first of all, the full form will be, it is American Society of Anesthesiologists. It is American Society of Anesthesiologists, and what they have given this ASA grading, and this ASA grading will be telling us about the physical status of the patient. Physical status of the patient. Physical status means what? The patient is coming to for pre-anesthetic checkup. During pre-anesthetic checkup, they are also checking the physical status of the person. Physical status of the person. So we are dividing this grading system into 1 to 6 grade. We are dividing this grading system into 1 to 6 grade. Okay, we can also divide on the basis of elective and emergency surgeries. Okay, we can also divide this on the basis of emergency and elective surgeries. For elective surgeries, elective means we can do surgery at any time, that is your 1 to 6 grade. For emergency surgeries, we are having 1E, 2E, 3E, just like that we are writing. Okay, so let's remember what are the different things that we are having in these grading systems. Okay, so we are having ASA grade 1. ASA grade 1 will be telling us about the, look here, ASA grade 1, that means the patient is without any organic, biochemical or psychiatric disease. Okay, there is a normal healthy patient, that means he do not have any kind of disease. ASA grade 2 will be having what? Mild systemic disease will be present. Okay, maybe the patient can have diabetes, maybe the patient can have controlled hypertension, maybe the patient can have obesity. So these are basically mild systemic diseases. Okay, ASA grade 3 will be telling us about the severe systemic diseases. That means the patient is having some kind of systemic diseases, severe. Okay, for example, the patient can have angina, the patient can have COPD like bronchitis, emphysema, or maybe there is prior myocardial infarction. Maybe the patient can have before the patient can have myocardial infarction. Okay, that is heart attack, right? Next we are having grade 4. Grade 4 will be, the patient will be having a disease which is constant threat to the life. For example, the patient can have CHF, patient can also have unstable angina, patient can have renal failure, acute MI. These are the example you have to remember, because nowadays the question they will be giving you the example. Okay, the patient is having unstable angina, that means it is a constant threat to the life. Okay, you need to identify the grade of the patient. Okay, these are type of question they can ask you. Okay, ASA grade 5, there will be moribund patient. ASA grade 5, the patient will be moribund. Okay, moribund patient, what are moribund patient? They are not expected to survive more than 24 hours. Okay, For example, ruptured aneurysm, and this was the question they have asked you. Ruptured aneurysm, the question they have asked you. Okay, grade 6 will be brain dead patient. They will be brain dead patients, and they will be having organ harvesting. Okay, there will be organ harvesting. There will be organ harvesting. Okay, so these are the grading system that we are having, that is including grade 1 to grade 6. Okay, now what will happen, try to understand. A patient is coming to you for some kind of surgery. You are sending the patient for pre-anesthetic checkup. You are sending the patient for pre-anesthetic checkup. During pre-anesthetic checkup, he will be doing some physical examinations. Then the patient then he will also do about the ASA grading, and then he will write in the paper. Okay, for example, the surgeon is for example, the anesthesiologist is writing ASA grade 1. He is writing ASA grade 1. That means the patient is healthy and we can operate at any point of time. But for example, if the anesthesiologist is writing about ASA grade 5, that means the patient is really sick. We need to take care of the patient as soon as possible. Within 24 hours we need to perform the surgery. Okay, so that is why this ASA grading is important. This ASA grading is important. Okay, next thing what we need to remember is about the airway. Okay, is about the airway. We are having this grading system. This is known as Mallam Patti grading. This is known as Mallam Patti grading. Okay, class 1, what will happen in the class 1? Everything will be visible. Class 1, everything will be visible. Class 2, there will be some kind of things will be lost. Okay, so basically this Mallam Patti grading is telling us about the, it will be the assessment of oral cavity. It will be telling us about the assessment of oral cavity with respect to size of tongue. With respect to size of tongue. And what is the mnemonic? How you will be remembering this? The mnemonic will be push. Okay, the mnemonic will be push. Okay, how you will remember? Class 1, guys, look here. Soft palate is visible. Uvula is visible. Forceps pillar is also visible. Everything is visible. So class 1 will be everything visible. Everything visible. How you will solve this question? Class 2 will be, just remember, P will be lost. Okay, so class 2, these pillars will not be visible. Okay, so there will be pillars will not be visible. Apart from pillars, soft palate, uvula, forceps, everything will be visible. Class 3, just remember U and S. Okay, what will happen? The base of uvula is visible. The base of uvula is visible. Along with that, soft palate is visible. Can you appreciate? Soft palate is visible, and also the base of uvula is visible. Apart from that, nothing is visible. Okay, so that is your class 3. And class 4 will be having only hard palate visible. Only hard palate will be visible. Class 4, only and only hard palate will be visible, right? So this is how you will be identifying. Okay, so class 1, remember, just revise it again. Class 1, everything is visible. Class 2, only pillars will be gone. Class 3, only base of uvula and soft palate will be visible. And class 4 will be only hard palate will be visible. This is what is known as Mallam Patti grading. Multiple times they have asked you this particular question. You have to remember this. Okay, next one is your Cormack-Lehan grading system. Cormack-Lehan grading system is a laryngoscopic view of glottic opening. Look here, guys, it is a laryngoscopic view of glottic opening. That means when we are putting the laryngoscope, then only what are the structures that are that we are seeing is known as Cormack-Lehan grading. Okay, is known as Cormack-Lehan grading. So class 3 and class 4, can you appreciate? You are not able to there is no visibility of the vocal cords. Okay, you are not able to see the vocal cords. So class 3 and class 4 are again difficult intubation here. That means what? When the patient is coming for like pre-anesthetic checkup, what is happening? We are assessing the patient. Okay, we are also assessing the size of the tongue of the patient. Okay, because during surgery, what we need to do? We need to intubate the patient. So how we will intubate the patient if we don't know whether if the patient may be having some difficult intubation? Okay, so we will be checking for that in the starting itself, right? That is why we are doing these things. Okay, that is known as pre-anesthetic checkup. This is your Cormac-Lehan grading, grade 1, grade 2, grade 3, and grade 4. Here you can appreciate these are your vocal cords nicely visible. So grade 1 and grade 2 we can easily intubate, but grade 3 and grade 4 will be a difficult intubation. Here also grade 3 and grade 4 will be difficult intubation, guys, difficult intubation. Okay, Bicho. Now try to solve this question. When assessing a patient before anesthesia, the oral cavity should be examined. The image below displays the examined cavity. It illustrates what? So can you appreciate which grade is this? Which grade is this? Carpal tunnel. So just remember push. Just remember the mnemonic push. How to solve these questions? You have to remember the mnemonic push. Okay, what are the different things? What are the different things you will be seeing over here? You have to see the push. Okay, P means what? Grade 1, it is already excluded because grade 1 everything is visible. Just try to eliminate the option. Grade 1, sir, everything is visible. Okay, so it cannot be grade 1. Grade 2 only. Grade 2, what will happen? Only pillars will be lost. Okay, grade 2 will be pillars will be lost. Pillars are lost, but apart from pillar, base of uvula is also visible. Only base of uvula is visible, and this is your soft palate. Soft palate. What you can see, soft palate and base of uvula is visible. Okay, so that would become grade 3. That would become grade 3, and grade 4 will be having only and only hard palate visible. Grade 4 will be having only and only hard palate visible. So what would be your answer, guys? Your answer will be very good, Rahul, carpal tunnel, Anuj, Shri. Okay, so that would be your C. That would be your C. That is your grade 3. Okay, try to solve this one. Identify the Mallampati class of this patient. Now try to solve this one. What you can appreciate over here, try to solve this one. Again, use the mnemonic push. Why I am giving you these questions repeatedly? Because they have asked repeatedly. Okay, so grade 1, everything visible. Grade 2, only pillars visible. Grade 3, base of uvula and soft palate visible. Grade 4 will be hard palate visible. What you can see here, only and only hard palate is visible. Only and only hard palate is visible. So your answer will be C. Answer will be C. That is your grade 4. Very good, Rahul, Shri. Okay, so that is the thing. Okay, now we will be discussing about the what is the appropriate pre-operative fasting recommendation. This was the question they have asked you. Okay, what is the fasting recommendation that we have to remember? Okay, for that you have to learn about the NPO orders. You have to learn about the NPO orders. Okay, what are the NPO orders that you have to see here? Look here. What is the meaning of NPO order? That is nil per oral orders. This is known as nil per oral orders. That means before surgery, when the patient will come for surgery, so what he needs to eat, he will be asking the anesthesiologist that sir, before surgery what can I eat? So before surgery, what patient can eat is known as NPO. So what are the things that patient can eat? 8 hours before surgery, look here, 8 hours before surgery, patient can have full fatty meals. Full fatty meals means what? He can have complete food. Okay, 6 hours before surgery, he can have semi solid food like dalia, khichdi, all those things. Okay, 2 hours before surgery, he can have clear fluid. He can have clear fluid 2 hours before surgery. In the pediatric patient, the same thing will happen, but you have to remember this particular thing. Okay, that is 4 hours before surgery, you can have breast milk. You can have breast milk 4 hours before surgery. Okay, so according to this, what would be our answer? What is the pre-operative fasting recommendation? What is our answer? Yes, if you want to eat biryani, you can have biryani as well. Class will be approximately 2 more hours. So what would be your answer? No, breast milk will be 4 hours, guys. Breast milk will be 4 hours. Okay, so answer will be second. Answer will be second. Okay, answer will be second. You can have liquid. Okay, you can have liquid, clear liquid 2 hours before the surgery. Okay, that would be second. Very good. Faiza, Anuj, Shri. Very good. Okay. Now we will be discussing about the pre-anesthetic order. Pre-anesthetic order, it will be telling us about the different drugs that the patient can take before the surgery. Okay. So for example, let's try to understand in the form of a story what is happening. A patient is coming to us for some kind of surgery. Okay, I will be sending my patient to anesthesia department. When the patient will be coming to anesthesia department, we will be doing a thing that is known as pre-anesthetic checkup. In pre-anesthetic checkup, I will be taking general physical systemic examination. Apart from that, I will be looking inside the oral cavity of the patient because I need to intubate the patient, and that is known as Mallampati grading. Second thing that I will do, I will try to put my laryngoscope and I will try to look for visual opening of the glottis, right? That is known as Cormack-Lehan grading. Okay, then what I will do, I will tell my patient that before surgery, these are the things you can eat. For example, tomorrow is the surgery in the morning, so in the night itself, you can have full fatty meals. Okay, if you want to have biryani, you can have biryani last night. Okay, a night before the surgery. Okay, but before the surgery, what you need to eat, you need to eat according to this NPO guidelines. Okay, now patient will ask, sir, I am taking certain drugs, I am taking certain drugs, should I continue those drugs or should I stop those drugs? Okay, so these are the drugs, what are the things that the patient needs to stop for elective surgery. Okay, for example, for elective surgery, let's say I'm doing surgery after 2 months. Okay, so I will tell the patient, please stop smoking, please stop smoking, right? So that is, smoking should be ceased how many times before? That is your 8 weeks before surgery, that means 2 months. Okay, HRT, hormone replacement therapy, that would be having high dose of estrogen as well as progesterone. Okay, herbal medications. Okay, we need to stop these also 6 to 8 weeks prior to surgery. TCA, tricyclic antidepressant, we need to stop 3 weeks prior to surgery. We can stop ticlopidine 13 to 14. Ticlopidine 13-14 ऐसे याद रख लो, ठीक है? That is in Hindi, right? Clopidogrel, we have to stop 5 to 7 days prior to surgery. Warfarin, we have to stop 4 days before to surgery. Lithium 24 to 48 hours. Heparin 12 to 24 hours, but unfractionated heparin we can continue 6 hours before the surgery. Okay, these are the important ones. Apart from that, they have asked question based on this. Apart from that, we are having oral hypoglycemic agent. Okay, oral hypoglycemic agent, these are the drugs like, sulfonylureas, all your OHAs. Okay, they will be having, these are the drugs. So you already know that you are coming hungry, right? So why do you need oral hypoglycemic agents, right? So you need to omit the last dose, you need to omit the last dose. Okay, if surgery is going to be for longer hours, you can shift the patient to, you can shift the patient to insulin, guys. Insulin. Okay, you can shift the patient to insulin. Antihypertensive, you need to continue because in surgery you can have hypertension. Okay, but two antihypertensive you need to stop. That is, your first one is your angiotensin receptor blocker and second one is your ACE inhibitor. Angiotensin receptor blockers like your sartans, all your sartan, telmisartan. Okay, and ACE inhibitors like your prils. Okay, captopril, lisinopril. Okay, aspirin, you can continue baby aspirin, that is a low dose of aspirin which is an antiplatelet drug, you can continue. Okay, thyroid medication you have to continue. These are the important ones that has been asked in your examination. Okay, now the patient already know what drugs he can take, right? What is the story that is going on? Patient is coming to us for surgery. Now we are doing PAC checkup. Now the patient will come next day, the patient will come for surgery. Okay, we have already told the patient what to eat, what not to eat. We have already told the patient what to have, what drugs he can have or what drugs he have to omit. Okay, now the patient is coming for surgery. Okay, so before surgery, just try to answer this question. Glycopyrrolate is used as a pre-anesthetic agent for, what is the function of glycopyrrolate, guys? What is the function of glycopyrrolate? Glycopyrrolate is an anticholinergic drug. It is an anticholinergic drug and it will be reducing the secretions. Very good, carpal tunnel. So it would be reducing the secretions. Why I want to reduce the secretion? Because when I am putting my laryngoscope, when I'm trying to intubate the patient, I just don't want any kind of secretions because that would lead to aspiration. To prevent aspiration, we are using this glycopyrrolate thing. Okay, now the patient is coming to surgery. Okay, for example, patient is having cholelithiasis, he is coming for surgery. Now what we need to do, look here, the patient is coming to the surgery department, and what he will be seeing, he will be seeing multiple instruments, scissors, all those things. So he must be very, very anxious. Okay, so how we can decrease the anxiety of the patient? We can decrease the anxiety of the patient by giving some drugs. These are known as anxiolytic drugs. Okay, कौन सी दवाइयाँ बोलेंगे? Anxiolytic drugs. These are your first one, benzodiazepine. Benzodiazepine, what are the drugs we can use? Try to answer, guys. We are having midazolam. Apart from that, we can also use diazepam. Okay, we can use midazolam, we can also use diazepam. So these are the drugs that you can use. Okay, apart from that, we are having anti-emetic medications. So anti-emetic medications are your 5-HT3 blockers. Okay, these are your 5-HT3 blockers. What are the name of the drugs? These are your ondansetron. We can give these drugs. Apart from that, we can also use metoclopramide. Okay, metoclopramide is basically a prokinetic drug that would be increasing the movements in your GIT, that would be leading to emptiness of the GIT. Okay, so that is basically a prokinetic drug. Apart from that, we can use antacid in the patient. We can use proton pump inhibitor, that would be leading to decrease in acid secretion. Decrease in acid secretion. Okay, what is the anti-sialogogues that we are using? That is your glycopyrrolate. We have already discussed, it will be decreasing your secretions. Okay, next we are having antibiotics. We can use third generation broad spectrum antibiotics. That, for example, broad spectrum antibiotics we will be using. Why we are using broad spectrum antibiotics? And when we are using antibiotics, try to answer, guys. We can use cefazolin, we can also use ceftriaxone. When we need to give this antibiotic, try to answer. This was the question they have asked you. So we need to give antibiotics 1 hour prior to surgery. We need to give antibiotics 1 hour prior to incision, guys. Incision. Why we are giving this drug early? Because other drugs, when during surgery, what we are doing, we are using other drugs also. So those other drugs will not react with our drug. That is why we are giving these antibiotics before, right? Second thing, try to answer this question. What is the preferred drug for pre-operative antibiotic prophylaxis in a patient who is about to undergo cardiac surgery? So what is the drug that you want to use? Yes, what is the drug that you want to use, guys? Try to answer. Carpal tunnel. Very good, Rahul, Anuj. Carpal, right? So that would be your D. Very good, Shraddha. So that would be your D. Basically, cefazolin is what? Penicillin is a cell wall synthesis inhibitor, right? Erythromycin, we are using erythromycin and azithromycin. They are both macrolides, and cefazolin is a broad spectrum antibiotic. It is a broad spectrum antibiotic. That is what we are using. This is a third generation cephalosporin, right? So we can use this particular drug for our patients. Okay, so now we will be discussing about intubation. Before intubation, let me recap everything that we have discussed by so far till now, right? So what we have discussed till now, we will be recapping everything just in a moment. What we have discussed about the introduction, we have seen about the different types of anesthesias that we are having. We are having general, we are having regional, we are having local anesthesia. Okay, so infiltration also we have seen. Then we will be discussing about we have discussed about the pre-anesthetic checkup. Pre-anesthetic checkup, the patient will be coming before surgery. Before surgery, anesthesiologist will be giving clearance to the patient. Okay, now what we will do, we have already given the drug to the patient, anxiolytics we have given glycopyrrolate, we have given everything, right? What we have discussed, we have given everything to the patient. Now our patient is on the bed itself, right? Now what we need to do, we need to start the treatment. Before starting the treatment, what we need to do, we need to intubate the patient. How we will intubate the patient, guys? How we will intubate the patient? Yes, we can continue OCP. OCP is low dose estrogen and progesterone, so we can use that. Okay. So intubation. What we need to do about intubation? First of all, intubation is done with the help of laryngoscope. Okay, laryngoscope की मदद से करेंगे. Second thing, we are having certain airway devices. When we are intubating someone, we are opening the oral cavity. We are looking under the vocal cords, and then we are putting some kind of device that is known as airway devices. Okay, it can be of two types. We are having two types of airway devices. We are having supraglottic airway devices which are working above the glottic opening. These are known as supraglottic airway devices, and those devices which are working below the glottic opening, that are known as infraglottic airway devices. Okay, so we are having supraglottic airway devices, we are having infraglottic airway devices, and we are also having some adjuncts. Okay, so supraglottic airway devices that we are having is, first one important one is laryngeal mask airway. Laryngeal mask airway, I would be showing you images and you will be identifying. Okay, second we are having infraglottic, that is going below the glottic opening, that is your endotracheal tube. These are your ET tubes. Okay, and third that we are having is your adjuncts. We are having oropharyngeal devices, we are also having nasopharyngeal devices. Oropharyngeal, the examples will be Goodell's airway, and nasopharyngeal will be nasopharyngeal tubes. Okay, so these are the basic devices that you have to remember. Okay, let's start with the laryngoscope. First of all, try to identify these structures. These are the types of questions that are being asked in your examination. Okay, so you need to identify the structures. Okay, first of all, try to identify first one. What is this? Try to identify this particular image. Okay, what is this? Try to identify. I'm waiting for your answers. This is Macintosh. Macintosh. Is this Macintosh? Try to answer, guys. Dr. Faiza Farooq, that is Mac. What if I say, for example, if I am the examiner, I would be asking you this type of question itself, right? Because you are seeing at the curved blade. You are looking at the curved blade. What you will be thinking that this is Macintosh, but this is not Macintosh. What you need to remember here, look here, there is an extra handle, guys. There is an extra handle. This is your source of light. Try to identify how do we see it. Source of light will be here. Okay, this is your handle. Okay, this is your extra lever. You can say extra lever is there. So if there is extra lever present, this is not a Macintosh laryngoscope. This is a McCoy laryngoscope, guys. McCoy. And this was the question they have asked you. McCoy laryngoscope. This is which one? McCoy laryngoscope. This is a McCoy laryngoscope. This is a McCoy laryngoscope. Okay. Moi moi ho gaya. Right. This is a moi situation because examiner knows what you will be answering, right? So this is McCoy laryngoscope. Okay. Second one, here you can see curved blade. Now you can answer your favorite burn. That is your Macintosh. Okay. Now, which is this one? Try to answer. This is a straight blade. This is a straight blade laryngoscope. Straight blade. And we are using this for children's, guys. Okay, we are using this for children's, and this is known as Miller's. Okay, this is known as Miller's laryngoscope. 2L you can remember like straight lines. Okay, so this is known as Miller's laryngoscope. Okay, can you appreciate this one? This is, we can see the video on the monitor itself, right? So this is your video laryngoscope. This is your video laryngoscope. Okay, next we are having is this one. What is this? Last one is your, try to answer. They will be asking question based on this itself, right? Try to answer this one. This is your fiber optic laryngoscope. This is your fiber optic laryngoscope. So first of all, you already understood the meaning of laryngoscope. What we have seen, now the patient is lying in the OT. हमारा patient कहाँ पर है? The patient is in the OT itself. Now we need to intubate our patient. We have already given different drugs to the patient, right? Now we need to intubate our patient. How we will intubate our patient? First of all, I need to have laryngoscope. Okay, these are the different types of laryngoscope. If you are finding this extra lever, remember guys, extra lever will be telling us about the McCoy laryngoscope. Okay, extra lever is there, McCoy laryngoscope. Curved blade will be Macintosh. Okay, straight blade will be Miller's, and this one is your video laryngoscope. Lastly, we are having fiber optic laryngoscope. Fiber optic laryngoscope. Okay, try to identify this instrument. Okay, try to identify this instrument. What is this? Is it a Goodell's airway? Is it a laryngeal mask airway? Is it an endotracheal device, or is it a nasogastric tube? What do you say? What do you say, guys? Till then, let's discuss about all the Goodell's airway, LMA. Wow, I'm getting different answer. Let me make it correct for you. Let me make it correct for you. These are incorrect answers that I'm getting. Try to understand. Okay, what are LMAs and how do we differentiate these supraglottic airway devices? इनको differentiate कैसे करेंगे? First of all, we are having this single opening. Try to understand what I'm telling you, how you will be identifying that. First one is your classical airway. This particular structure that you are looking at, this is known as pilot balloon. This is known as pilot balloon, and here you are having this single opening, bacho. Single opening is there, and this is known as classical LMA. This is known as classical LMA. Okay, here try to understand, this is fast track. Here you will be finding double opening. Here you will be having two opening. This is known as fast track LMA. This is known as fast track LMA. How you will identify? You will be having an extra handle here. Okay, you will be having an extra handle here, and you will be having this curved structure. Okay, these are the important points that you have to remember. Two openings, what you have to remember, two openings will be there, handle will be there, extra handle, and it will be curved, right? That would be your fast track LMA. Next one is your proceal. Here also you will be having these two openings. Okay, this is a straight, this is straight, and this is your pilot balloon will be present. Okay, next one that we are having is your this one. This is known as LMA supreme. Sir, how to identify LMA supreme? Can you appreciate it is curved? Second thing, you need to look for this fixation tab. Fixation tab will be there. You will be having these two opening again. Okay, this one is curved. Okay, so supreme will be curved and it will be having a fixation tab. Okay, here can you appreciate, here pilot balloon is present. This is your IGL will be having absence of pilot balloon. There is no pilot balloon. There is no pilot balloon. Okay, and look here, this one is also having how many opening? It will be having two opening, but this one will be having pilot balloon will be present, and this is known as LMA umbu. Okay, so what we have seen 6 of them, and the most important are how to differentiate. Okay, so let's see one by one. Single opening is there, pilot balloon is present, that is your classical LMA. Single opening, classical. Okay, double opening is there, handle is there, and it is curved, that is your fast track LMA. Straight one will be proceal. How you will differentiate proceal from supreme? Supreme will be having a fixation tape and it is curved. Okay, and this one will be having colorful. Two of them are colorful. First one is your IGL will be having absence of pilot balloon, and this is your LMA umbu. It will be having pilot balloon, right? So this is how you will be differentiating between all of them, right? Now try to answer which one is this. Which is this? LMA. This is a LMA, we already know, but out of LMA, which one is this? This is your IGL. IGL. Very good, Shri. Okay, so this is your IGL. Try to answer this particular question. Identify the given instrument. Now try to utilize what you have learned. Okay, is it the question is very simple, but try to identify which one is this. Try to identify which one is this. Try to answer which one is this. Is it a supreme? Is it a IGL? Is it a umbu? Is it a classical airway? Is it a proceal? How you will identify? So if fixation tab is present, remember guys, fixation tab is present here. Can you see fixation tab is present here? So that would be LMA Supreme. Very good, very good. Now you can identify in examination also. Okay, in examination you will be understanding this. Okay, so we are having this fixation tab present, that means it is a LMA Supreme. This one is your IGL, this one is your AMBU. Okay, now try to solve this question. Where can the devices in Murphy's eye be observed? Murphy's eye will be present in which device? Murphy's eye will be present in which device? Okay, try to answer. Murphy's eye will be present in, very good Shri, that would be present in your endotracheal tubes. Okay, so endotracheal tube is a supraglottic airway device, or is it an infraglottic airway device? Okay, supraglottic airway devices we have seen there, these are your LMAs. Okay, supraglottic we have seen, these are your LMAs. So we will be discussing about infraglottic devices now. Okay, so we are having these endotracheal tubes. Endotracheal tubes can be, so it can be cuffed tube, it can be uncuffed tube. It can be cuffed, it can be uncuffed. Okay, this is the structure, this is known as Murphy's eye. This is known as Murphy's eye. For example, look here, if this end is getting blocked, for example, if this end is getting blocked by intubation, this is for the purpose for giving oxygenation to the patient. Okay, sometimes you know what happens, this part is getting blocked. Okay, that is why we are having another opening that is known as Murphy's eye. This opening is known as Murphy's eye. This opening is known as Murphy's eye. Okay, we are having a specific line that is known as vocal cord guide. Okay, and the diameter will be written here, that is 8.2. Diameter is written here, and it will be having a universal connector. Okay, universal connector. For example, we are having C-type charges nowadays. Okay, so every phone will be having same charges. Just like that, every device will be having this type of universal connector. Okay, we can also appreciate the pilot balloon. Okay, and these are the radio markers. Okay, these are the radio markers. Next one, resistance of the tube shown below is primarily because of. This was the question they have asked you in FMGE June 2021. Okay, try to answer. Try to answer this question. Thank you, sir. Thank you. Thank you, Sandeep, sir. Okay, try to answer this question. Resistance of the tube shown below is primarily because of. That is because of diameter, guys. That is because of diameter. That is because of diameter. Okay, try to answer this one. What is this device called as? What is this device called as? Can you appreciate two openings here? Can you appreciate two openings here? So this is a double lumen tube. This is a double lumen tube. Okay, this is a double lumen tube. We are having different things, guys. Let's see one by one. We are having different types of tubes. Okay, so first one is your RAE tubes, ring Adair Elvin. What is the full form? Ring Adair Elvin tubes. These are the names of the scientists. Okay, so we are having two types of tubes here. Look here, we are having two types of tube here. One is known as south facing tube, another one is known as north facing tubes. Okay, so north will always be in the upper direction in the map itself, right? So the upper direction tube will be north facing tube. This is your upper direction tube, and this is how you have to remember, that is your north facing tube. Okay, this is your north facing tube, and this one is your south facing tube. This one is your south facing tube. Okay, you can also remember both of the direction are going in the same direction. You can remember S for same, as for south also. Okay, so that is your south facing again, and this one is going in the opposite direction. This is your north facing tube. Okay, this is how you have to remember. First tube is your RAE tube. First tube is your RAE tube. This is your red rubber tube. What is this? Red rubber tube. Red rubber tube. Where do we use this red rubber tube? Remember, guys, this red rubber tube we will be using for CO2 laser surgeries. Okay, so we are having CO2 laser surgery, and in those surgery we are using this particular tube that is known as red rubber tube. Okay, look here, guys, this is your flexometallic tube. This is your flexometallic tube. Why flexometallic? Because it is kink resistant. Okay, it is kink resistant. For example, we need to perform some neurosurgery. Okay, so to prevent the kink, okay, to prevent the kink, what we can use? We can use kink resistant tubes. It will be having it will be having kink resistance. Okay, so that is your kink resistant tube. Okay, that is also known as flexometallic tubes. Okay, this one we have already discussed. This is your 2 lumen, you can appreciate. So this is your double lumen tube. This is your double lumen tube. 2 lumens will be present here. And where do you use this particular type of tube? We will be using these tubes in ventilating a single lung. Ventilating a single lung. Ventilating a single lung. Single lung. Okay, so if I want to ventilate a single lung and I want to perform the surgery on the another lung, what I can do, I can use this type of tube that is known as double lumen tube. Okay, this is a stylet, guys. This is a stylet, and this one is a boogie. Okay, what is the function of them? The function will be, it will be facilitating us to insert the ET tubes. Okay, it will be helping in insertion of the ET tubes. Apart from that, these are your ET tubes, important ET tubes. I have already gathered everything here, right? So you can see. Okay, next one is your about the adjuncts. Okay, we are having different adjuncts. What we have seen, we are having 2 types of adjuncts. First one is your oropharyngeal, second one is your nasopharyngeal. Try to see here. First structure that you can see here, this is known as Goodell's airway. This is known as Goodell's airway. This is known as Goodell's airway. How we are putting that Goodell's airway? We will be putting, the tip should be facing the roof of the mouth. Okay, look here, the tip should be facing the roof of the mouth, and then what we can do, we can rotate it. Okay, then we can rotate it. So this is how we are putting the oropharyngeal adjuncts. Okay, and second thing, the most important, they have asked you question about is how do we assess the size of this this adjunct. Okay, so the size will be assessed by the angle of mouth to the angle of mandible. Look here, from the angle of mouth to the angle of mandible, this is how we are assessing the size of this particular thing, right? This is known as Goodell's airway. This is known as Goodell's airway. Okay, next one is your, these are your nasopharyngeal devices. These are nasopharyngeal devices, and again they have asked the question, how do you assess the size of these nasopharyngeal devices? So you will be assessing the size from tip of nose to the tip of ear lobule. This is how you will be assessing the size of these nasopharyngeal tubes. Okay, they are your adjuncts. They are your adjuncts. Okay, so what we have discussed till now, we have discussed about laryngoscopes, and we have discussed about the different types of supraglottic and infraglottic airway devices, and also we have discussed about the Goodell, we have discussed about the adjuncts. Okay, so we have seen laryngoscope, different types of laryngoscope. We have seen supraglottic airway devices, how the questions are being asked. We have discussed the infraglottic airway devices. We have also discussed about the adjuncts. We are having oropharyngeal devices. They will be asking question, how do you assess the size? And then we have discussed about the nasopharyngeal devices, and then they will be asking how you will assess the size. Okay, this one is extra lever will be McCoy. Okay, this one is video laryngoscope. This is how you have to remember. Okay, इनको एक बार देखेंगे, once more we will be looking at all of them, and you will be remembering everything, right? So all the questions are already here. Just try to answer this one. Okay, which of the following statement is false regarding intubation? Try to answer this particular question, guys. Which of the following statement is false regarding intubation? Do we do intubation in a morning sniffing position or flexion of neck? Is it right? Try to solve one by one. Is it right? How many says B? Very good, Sri, Rahul, Venugopal. First of all, let's see one by one all the statements we will be discussing about. Okay, so first statement is morning sniffing position or flexion of neck. First of all, just try to understand what they want to know. They want to know the false statement. They want to know the false statement regarding intubation. So how we will do intubation? We are having, now we have already discussed about the all the devices. Okay, we are having laryngoscope, we are having endotracheal tube, right? Now we will be performing, our patient is already lying in our OT table. Now we will be performing our intubation. So how we will perform our intubation? First thing, the position of the patient will be morning sniffing position. Okay, morning sniffing position, that is this position. Okay, and the patient will be having flexion of neck. Okay, flexion of neck should be there. Okay, so it is a true statement. It is a true statement. Okay. Second, introduce the laryngoscope from the right hand. I don't know about this. Let's discuss the other options. Okay, this one is suspected. Okay, push the tongue away and see the epiglottis and then visualize the glottic opening. Yes, it is very true. Okay, next, introduce the ET tube and inflate the cuff. This one is very true. Okay, check for bilateral breath sound and fixation of the ET tube. This one is also true. So what would be your answer then? Your answer would be statement number 2 is false. Why, sir? Always remember that laryngoscope we will be holding in which hand? That is in your left hand, non-dominant hand, right? That is your left hand. Okay, so this is a false statement. So what you will be doing, the patient is lying down. Let me tell you how to do intubation. The patient is lying down. What you will be doing, you will be putting the patient in morning sniffing position or barking dog position. Then you will be introducing the laryngoscope from left hand, and you will push the tongue away, and then you will see the glottic opening. Once you visualize the glottic opening, you will put the endotracheal tube from the right hand. Okay, and then you will inflate the cuff, and then you will check for the bilateral breath sounds. Okay, then this is how you are doing the, and then lastly you will be doing the fixation of the ET tube. This is how you will be doing the intubation. Now I have done intubation in my patient. Now what will happen? There are some questions that you have to solve. What is the specific action that is being demonstrated in the provided image? This was the question they have asked you. Try to answer this one. So what is this particular thing the doctor is trying to do? Very good, Sai Priya, Shri. Okay, this particular maneuver is known as, very good, carpal tunnel, Rahul. So this particular maneuver, try to look here. The head will be having the hand, and the another hand will be on the chin, right? So this is a head tilt and chin lift. This is a head tilt and chin lift we will be doing for difficult intubation. Okay, this one is, try to answer this one. What is this? Is it head tilt or chin lift or jaw thrust or head extension, inline manual stabilization? What is that? What is this one? What is this one? Try to answer. Very good. B. Pinto, Rahul, Sai Priya, carpal tunnel. Everyone is answering, right? Wonderful, guys. So this is your jaw thrust. Jaw thrust will be done for which patient, guys? It is done for trauma patient, and these are the image based question they have asked you. Okay, so try to understand. This first one is your head tilt and chin lift. Why we are doing this? To visualize the glottic opening, because we need to put the tube. Okay, jaw thrust we are doing for the trauma patient, because we don't know if trauma patient is having some problem in the atlanto-occipital joint. Okay, the patient can be having problems here, right? So what we need to do, we need to do this particular movement for opening of the for visualization of the glottic opening, that is known as jaw thrust for trauma patient. Okay, this one is your Salix maneuver. What is Salix maneuver? We are putting pressure on the cricoid cartilage. Okay, we are putting pressure on the cricoid cartilage. Why we are putting pressure? To prevent the aspiration. Okay, we will be pushing the cricoid cartilage and we will be collapsing the esophagus to prevent the aspiration. Okay, so that we cannot aspirate. Okay, so the patient cannot aspirate. Okay, very good, guys. Okay, now we will be discussing about the monitors. What we have done, the patient is coming to us. Again, we are revising the story. The patient is coming to us for surgery. Now patient is already lying down in the position. What we have done, we have put at the endoscope, we have put at the laryngoscope, we have put at the endotracheal tube. Now we are connecting the patient to the monitor. Now still the patient is awake, he is looking at the things. Okay, what are the different things he can look in the OT itself? There will be some kind of monitors. But what are the things he will be looking? There will be some kind of monitors, and we can also see these are the 5 mandatory monitors that you have to remember according to standard protocol 1 or 2. Okay, so first, what are these 5 mandatory monitor? First one is your ECG monitoring. In ECG, we will be looking for 2 leads. First one is your lead number 2, that would be telling us about which arrhythmia. Any kind of arrhythmia, if there is in the patient, that would be telling us about the arrhythmia. And second lead is lead number 5, that would be telling us about the myocardial infarction. Okay, second thing that we are having is about the SpO2. That is the SpO2 will be telling us about the partial pressure of oxygen, it will be telling us about the oxygen saturation. Okay, so oxygen saturation will be told by SpO2. Okay, SpO2, and this is done with the help of pulse oximeter that we are putting in the finger itself. It is based on Beer-Lambert law or law of plethysmography. Okay, third thing that we have to have is your NIBP, that is your non-invasive BP monitoring. That is your non-invasive BP monitoring. We are putting the cuff. Okay, then we have to look for temperature. For temperature, we are having a catheter that is known as pulmonary artery catheter. That is the most sensitive one. Okay, that is the most sensitive one, but we are not using that for every patient. Okay, what we will do, remember, I'm not talking about the body temperature, I'm talking about the core temperature. Okay, so this is your pulmonary artery catheter, which is the most sensitive one, but we are using, we are putting the temperature probe in the lower one third of esophagus. Okay, lower one third of esophagus, that is what we are doing most commonly. Okay, so we are having 5 mandatory monitor. What are they? First one is your ECG, second one is your SpO2, third one is your NIBP, fourth one is your temperature, and lastly we are having that is your capnography, guys. Capnography will be telling us about the EtCO2. It will be telling us about the end-tidal CO2. Okay, whatever CO2 that is coming out, it will be shown graphically over here. It will be shown graphically over. This is known as capnograph. Okay, now try to answer this question. What is the most frequently employed method of monitoring the level of anesthesia? Okay, how you will monitor the anesthesia here? Okay, yes, inline is that. Okay, yeah, that is right. 35 to 45, yes, that is right. Okay, so what is this? Yes, Dr. Vicky, BSI, depth of anesthesia. Very good, guys, very good. So this is your BIS monitor. Okay, 5 monitors I have told you. What are these 5 monitors? ECG will be there, SpO2 will be there, NIBP will be there, temperature will be there. Apart from that, we are having capnography. Okay, but we are also having some more monitor. The first one is your BIS, that is your bispectral index. Let me tell you what is a bispectral index and what it will be telling us about. So this is your bispectral index. Whenever you see this type of image, this is your bispectral index. Whenever you see this type of image, it will be telling us about the depth of anesthesia. It will be telling us about the depth of anesthesia. It will be telling us about the depth of anesthesia. Okay, the value will be 0 to 100. The value will be 0 to 100. So 0 means the patient is in the coma and 100 means the patient is fully awake. So we need to put our patient in a range between 40 to 60. Whenever we will see that the patient is about to wake up, what we can do, we can repeat the dose of anesthesia. Okay, we can repeat the dose of anesthesia. Second one that we are having is your neuromuscular monitoring. This one is your neuromuscular monitoring. This one is your neuromuscular monitoring. And which is the most common nerve that we are using, guys? Which is the most common nerve? Very good, that is the most common nerve is ulnar nerve. Okay, most common nerve is ulnar nerve. We are giving a train of 4 response, and then we will be checking for the muscle relaxation. Okay, that is for the neuromuscular monitoring. Okay, this one is your central venous line. This one is your central venous catheter. This one is your central venous catheter. Okay, and this one multiport, this is your Swan-Ganj catheter. This is your Swan-Ganj catheter. Okay, this is your Swan-Ganj catheter we are using for, this is also known as pulmonary artery catheter. This is also known as pulmonary artery catheter. This is known as Swan-Ganj catheter, also known as pulmonary artery catheter. Okay, so these are the 4 points that you have to remember. Now try to answer this one. Which of the following is most effective approach for verifying the accuracy of intubation during laryngoscopy? Try to answer this one. Try to answer this one. What is the most effective approach for verifying the accuracy of intubation during laryngoscopy? How you will identify that your intubation is good? Very good, Upasna, Vicky. Okay, so that would be via capnography. That would be via Capnography. Remember, I've told you it is a graphical representation of EtCO2. So CO2 कहाँ से आएगा? CO2 will be definitely coming from your lungs, right? So whenever there is expiration, whenever there is expiration, what will happen? That CO2 will be coming via machine, and that would be shown graphically on the screen, on the monitor, you can see. Okay, try to solve this one. What is the most effective way to verify the placement of endotracheal tube in a 30-year-old patient, okay, who has been intubated for surgery by a final year resident? Okay, again, try to answer this one. Try to answer this one. What is the most effective way? How you will identify? Everyone is saying auscultation. Auscultation, why? You can check end-tidal CO2. Okay, you can also check end-tidal CO2. EtCO2 is what? EtCO2 is graphical representation of CO2. That is nothing but your capnography. That is nothing but your capnography. Capnography is the short confirmation. If it is given in the option, why you will be going for another options, right? If there is no capnography, then we will be going for auscultation or other things. Okay, so your answer will be C here, guys. Okay, answer will be C here. Okay, now we will discuss about capnography. Now we will discuss about capnography. Okay, what is capnography? Basically, capnography is the graph that would be showing us about the representation of EtCO2, whatever expired CO2 that is coming out from your lungs, right? CO2 will not come from esophagus. If there is problem, we will be identifying that very easily. If CO2 is coming, that means there is short confirmation that the ET tube is in the lungs, right? ET tube is in the trachea itself, right? So we are having capnography. Capnography. Okay, so what is metabolism? Metabolism में क्या होगा? What is metabolism? Metabolism is basically sum of catabolism plus anabolism, right? So whatever reactions that are going on in your body, they will be generating what? CO2. They will be generating CO2, and that CO2 will be coming out from your lungs, and that is what is giving you the capnography. Okay, what are the stages that we are having? Look here, we are having, this is your respiratory baseline. So whenever the patient will whenever the patient will expire, whenever the patient will do expiration, what will happen? This graph will be increased. Okay, this graph will be increased. Okay, then after that there will be a plateau phase. There will be a plateau phase. Okay, there will be a plateau phase, and then there will be this phase. This is known, this is the question they have asked you. When do you measure the levels of EtCO2? I am talking about EtCO2. Here is the point, that is your end of phase 3 will be the point where you will be checking the level of EtCO2. Then this is your inspiration. Again, because of inspiration, what is happening? Basically, we are checking the levels of CO2. Okay, so what is happening? First phase is your inspiration, first phase is your expiration, then there will be some plateau, because of gases exchange will be occurring inside the alveoli. Okay, and the question they have asked you, where do you measure the level of EtCO2? Then your answer will be at the end of phase 3. Okay, and then this phase is your inspiratory phase. This phase is your inspiratory phase. Okay, this phase is your inspiratory phase. Okay, so this is the normal capnograph. Okay, now this is your expiration, this is your plateau, this is your inspiration. Again, this is your expiration, plateau, inspiration. Okay, this is how the graph is. Okay, now we will be discussing about the important graph that we have to remember. Okay, the normal value of EtCO2 will be 35 to 45 mm of Hg. Okay, now we need to discuss about the some important graphs. Okay, just remember, as it is, the exam is near. Okay, this one is your shark fin pattern. This is known as shark fin pattern. क्या बोलेंगे इसको? शार्क फिन पैटर्न. ओके, वेयर डू यू फाइंड दिस पर्टिकुलर थिंग? इन पार्शियल ऑब्स्ट्रक्शन. इफ देर इज पार्शियल ऑब्स्ट्रक्शन, is if there is bronchial asthma or there is bronchospasm. So these are the condition that would be telling us about this particular thing, that is your shark fin pattern. Okay, you will be finding shark fin pattern here. Okay, second one, this particular notch that you can appreciate here, this is known as Curare's notch, and Curare's notch will be indicative of return of spontaneous ventilation. Okay, that would be telling us about the return of spontaneous ventilation, that means the patient has started ventilating himself. Okay, the patient जो है वो खुद से सांस लेने लगा है, that is known as return of spontaneous ventilation. That means patient is starting to breathe himself, right? What we need to do, we can repeat the dose of anesthesia. Okay, this one, if you are seeing the graph which is above the baseline, okay, if the graph is above the baseline, if the graph is above the baseline, what it would be indicating, graph above the baseline will be telling us about what? It will be telling us about CO2 rebreathing, guys. It will be telling us about CO2 rebreathing. It will be telling us about the CO2 rebreathing. CO2 rebreathing, when you will see, if we will talk in the terms of closed circuit, there will be exhaustion of soda lime. Okay, soda lime exhaustion can lead to this CO2 rebreathing. Apart from that, if there is problem in the circuit itself, okay, if there is problem in the circuit, so these are the points that you have to remember. Okay, now try to solve this one. What is the parameter being assessed by the device depicted in the provided image? Okay, what is this device? This device is, try to answer this one. Tell me, Bachu, what is this? This is your pulse oximetry. This is your pulse oximetry that you have seen in your COVID-19 also. This is your pulse oximetry, and this is based on which law? Beer-Lambert's law. This is based on Beer-Lambert's law, or law of plethysmography. Okay, law of plethysmography. Okay, so what it will be measuring? Pulse oximeter, I know, but answer will be Sharda Sai. Yes, it will be telling us about the oxygen saturation, guys. It will be telling us about the oxygen saturation. Okay, किसके बारे में बताएगा? It will be telling us about the oxygen saturation. Try to solve this one. A 40-year-old patient is undergoing surgery under some anesthetic agents. Suddenly during the surgery, his EtCO2 value are crossing 100 mm of Hg along with high temperature of the body. What could be the possible reason for this particular scenario? Okay, what could be the possible reason for this particular scenario, guys? What can be the thing that can happen over here? Okay, first of all, make the diagnosis, guys. First of all, make the diagnosis. Okay, try to understand the question, what the question wants to know. A 40-year-old patient is undergoing some kind of surgery. Okay, patient is undergoing some kind of surgery, and some anesthetic agents we are already using. During the surgery, his EtCO2 value has crossed 100 mmHg, right? So that is too much increase in the EtCO2 value, along with high temperature of the body. What could be the possible reason for this scenario? What can be the possible reason and what cannot? So answer will be what? Some of you are saying A, B, C or D. Try to answer. First of all, you guessed it right. This is the diagnosis will be, this is the case of malignant hyperthermia. This is a case of malignant hyperthermia, guys, because you can already appreciate we are having increase in temperature. Okay, do you know how it is happening? Okay, just try to understand. We are having a receptor that is known as ryanodine receptor. Okay, ryanodine receptor will be having mechanical relation with the dihydropyridine receptor, and they will be activating what? They will be going to your sarcoplasmic reticulum. Okay, sarcoplasmic reticulum will be having storage of calcium, and what it will do, it will lead to release of calcium. It will lead to increase in release of calcium. Calcium, remember, only three function. Calcium will be contraction. Always any muscle, it will be causing contraction. In vessel, it will be causing constriction. Okay, in any vessel it will be causing constriction, and whenever we will talk in the terms of any cell, it will be causing what? Exocytosis. It will be causing exocytosis, right? So now what will happen? because there is some kind of mutation in the ryanodine receptor, there is a disease that can happen that is known as malignant hyperthermia. What will happen in the malignant hyperthermia? This ryanodine receptor will bind with dihydropyridine receptor, leading to release of calcium, and this calcium will be producing contraction in the body, right? It will be producing contraction in the body, and the drug of choice that we are using here is IV sodium dantrolene. IV sodium dantrolene, right? Very good. That is your IV sodium dantrolene. Okay. So problem is in this particular receptor. Now they are asking all of the following agent can cause malignant hyperthermia. Okay, which one cannot? Which one cannot cause malignant hyperthermia? So your answer would be which one is the safest that which one is the safest they want to know. Okay, so which one is the accept, that would be your propofol, guys. Propofol. Any inhalational agent can cross react with this ryanodine receptor. Succinylcholine is the most common cause that you already know. It is just like acetylcholine. So basically what will happen, impulse will come from the neurons, right? Impulse will come from the neurons from in the form of acetylcholine, and acetylcholine will be having receptors, right? So these receptor will be going and binding to your ryanodine receptor. Okay, this will be going and binding to your ryanodine receptor. So your answer here would be Bacho, your answer would be propofol. Did you get it? Okay, try to solve this one. A 46-year-old chronic smoker comes to the emergency department. There is a chronic smoker who is coming to emergency department with a history of difficulty in breathing. There is a history of difficulty in breathing. Okay, and fever for last 1 day. Which of the following pin index number cylinder we can use to connect with the face mask of this patient? Okay, so there is a case, there is a patient who is coming to you. So first of all, try to identify what is happening here. The patient is having problem in breathing, right? The patient is having dyspnea, right? The patient is having dyspnea, and for dyspnea what you will be giving, you will be giving oxygen. And what is the pin index of oxygen? They are, instead of asking directly, they are giving you case and you have to answer. Your answer would be D. Your answer would be D. I would be telling you how to identify this. Okay, how to identify this. First of all, try to answer this one. Which color combination is commonly associated with nitrous oxide? Okay, nitrous oxide, which color combination is associated? Oh, it is already written, right? Try to look here first. Okay, try to look here. We are having now anesthesia machine. Where was our patient? Our patient is already lying in the OT. We have already put it the endotracheal tube. We have already intubated our patient. We have already done everything, right? We have seen all the monitor. The patient has already seen the monitor. He already know we are having 5 monitors. These are 5 mandatory monitors. Apart from that, patient has seen everything, right? Now we will be connecting our patient to anesthesia machine. Okay, now what we are going to do, we are going to connect our patient to anesthesia machine. Very good, guys, you are answering very fast, right? So what we need to do, to why we are adding anesthesia machine, how and why it is important? Okay, to decrease the pressure. First thing, the anesthesia cylinders will be having too much pressure. For example, the cylinder of like oxygen will be having 2000 psi. Okay, cylinder of nitrous oxide will be 760 psi. So that is too much of pressure. Okay, our lungs cannot directly tolerate that much amount of pressure, right? So we need to decrease that pressure. Sir, how we will decrease that pressure? With the help of this particular machine. This is known as anesthesia machine. How and what are the things that we are going to do, and what are the different parts of this particular machines we are having? Okay, so this anesthesia machine will be having a function, that is it will be decreasing the pressure. Second thing, it will be mixing the gases in the known concentration. Okay, we will be having different types of inhalational agents. We are having nitric oxide, we are adding halothane, sevoflurane. So all this mixing of the gases is also done in this particular machine, that is anesthesia machine. What we need to do, these are the monitors that we have already seen. These are your vaporizers. Just try to identify what are the different things you can appreciate in this particular machine. Okay, now let's see what are the different parts of this particular machine. We are having three parts of this particular machine. One is known as high pressure system, another one is known as intermediate pressure system, and third one that we are having is low pressure system. Low pressure system. Okay, so basically we are having three parts, and three parts will be having some important points that you have to study. At this point of time, I will be giving you the most important point that you need to remember. Okay, so the first one is your high pressure system. In high pressure system, we are having a safety system that is known as pin index safety system. That is known as pin index safety system. Pin index safety system, what is the meaning? it will be having it will be having certain pins. Okay, so that what is the function of this particular thing? It will be utilized to prevent incorrect attachment of cylinder. For example, you are in the mood and instead of oxygen you just want to give nitrous oxide to the patient. Okay, what nitrous oxide will do? Nitrous oxide is also known as kya bolte ho? What is the another name for nitrous oxide? Try to look here. We are having air, we are having oxygen, we are having N2O. Okay, we are having CO2, again CO2, and we are having cyclopropane. Okay, we are also having Antonox. So this is how we are remembering the pin index of these things. Okay, so air will be, just try to remember, we have to write 5 here, 5 here, 5 here. Okay, so air will be, A is the first letter, so it will be 1 5, pin index will be 1,5. Oxygen are two things. Okay, so that would be 2 5. Nitrous oxide 2 plus 1, that is 3 5. So nitrous oxide pin index will be 3 5. CO2, C just looks like 6. Okay, here C looks like 6, here also C looks like 6. Okay, here also C looks like 6. So what we can do, if it is more than 7.5%, if it is more, what we can do, we can give a number that is 1. If it is less, we can give it 2. And cyclopropane will be 3. Cyclopropane will be 3. That is your 3 6. Okay, 3 6. And Antonox, count the number 1 2 3 4 5 6 7. So it will be having pin index of 7. What is Antonox? Antonox is N2O. It is N2O and oxygen. Antonox is what? N2O and oxygen. That is your Antonox. Okay, that is your Antonox. Okay, now try to understand the color coding. Now I think you must have got it. For air, the pin index will be 1 5. For oxygen, we are having two things, so that would be your 2 5. Here we are having 3 5. Here we are having 1 6, 2 6, and 3 6. These are the important ones that you have to remember. Okay, now let's see the color coding. Okay, the color coding of the cylinder. Air will be having black body and shoulders, and black and white quarters will be there. Okay, I will be showing you the image. Oxygen will be black body, white shoulder, you already know. Nitrous oxide will be Neela, and for Neela that would be blue color cylinder. Carbon dioxide will be gray color. Cyclopropane, that would be cyclopropane, you can remember sun 3 in Hindi, that is your orange. Okay, Antonox will be blue body and shoulders with blue and white quarters. Okay, so these are the cylinders that you have to see. Okay, they can ask you question directly. So this is your black body and white shoulder. This is the cylinder of what? Oxygen. Okay, this is your complete blue cylinder, that is the cylinder of nitrous oxide. This is your orange cylinder, that is your cyclopropane will be orange cylinder. Okay, and lastly we are having this one again, N2O cylinder. Can you appreciate these are things, these are known as pin index. Okay, ye hote hain pin index. Can you appreciate this? Okay, these are the pin index. Okay, so in high pressure system we have to remember pin index safety system. Okay, यहाँ पर क्या होगा? Here we are having high pressure, here. So cylinder will be connected here, and these cylinders we have to remember. Then coming on intermediate pressure system, it will be having multiple things. The most important that you have to remember is DISS. That is your diameter index safety system. This is known as diameter index safety system. Okay, diameter index safety system. What would be pressure over here? The pressure here will be approximately 55 to 60 psi. Okay, in high pressure system, the pressure is approximately for nitrous oxide 760, For oxygen, that would be 2000. That is too much of pressure, right? Here the pressure will be in the intermediate range, that is 55 to 60 psi. Another thing that you have to remember over here is emergency oxygen plus. Just remember what I'm telling you. Emergency oxygen plus is a feature of intermediate pressure system. Okay, then we are having these flow control valves. Okay, these are basically color coded valves. Okay, these are basically color coded valves. Okay, now tell me the color of these systems. Okay, these are the pipelines. Have you ever been to hospital? In hospital you can appreciate there are some pipelines which are going on, right? There are some pipelines which are coming near the patient's bed. Okay, these are known as diameter index. These are known as the gases will be coming, but the pressure will be approximately, the pressure there will be approximately 55 to 60 psi. Okay, for air will be looking black in color, so that would be black. Okay, air will be black. Yellow, you can extend it v to y, so that would be your yellow. Okay, oxygen is important, so oxygen will be white. Very good, Rahul. And N2O will be blue. Okay, N2O will be blue. Nitrous oxide is already blue, so we can remember that is blue. Oxygen is important, so that would be white. Vacuum, you can extend the V into Y, so that would be yellow. And air will be black. Air will be black, so that would be air will be black on the X-ray, right? So air will be black. That is how you can remember. Okay, these are diameter index safety system. Okay, here also you cannot attach the wrong pipes. Okay, you cannot attach the wrong pipes. Okay, there will be particular diameter for particular tube. Okay, particular diameter for particular tube. Okay, this is known as diameter index safety system. Lastly, we are having low pressure system, guys. Low pressure system will be having flow meter. Just remember, flow meter is present in low pressure system, whereas flow control valve is a feature of intermediate pressure system. This is what I want you to remember. Okay, in exam you will be forgetting these things. Okay, so what is the function of flow meter? Flow meter will be telling us about the flow of gases. Okay, we are having these things. These are known as vaporizer. These are known as vaporizers, guys. इनको क्या बोलते हैं? We call it vaporizers. And we are having different color of vaporizers. First one we are having is this yellow one. Yellow one will be, it's all about color coding, guys. Yellow one will be, yellow is like sun is like yellow, so that would be sevoflurane. Okay, purple is isoflurane. This one is your halothane. Red is halothene. Okay, and blue one is your desflurane. Can you appreciate all these three cylinders are looking alike? All these three cylinders are looking alike, but this one is different. This one is a little bit different. So this is known as Tech 6 vaporizer. Tech 6 vaporizer. This is known as Tech 6 vaporizer, and we are using this particular thing for desflurane. Okay, so all these three vaporizers are normal vaporizers, but for desflurane we are using a special vaporizer that is in the blue color, and that is known as Tech 6 vaporizer. What is the name of this particular thing? That is your Tech 6 vaporizer. Very good, guys. Okay, now we will be discussing about the question. Blue pipeline supply carry which gases? Okay, blue pipeline में कौन सी gases होगी? What is the gas that would be having in the blue pipeline? Try to answer. Blue one will be very good, Sahana. That would be nitrous oxide, guys. Nitrous oxide. Oxygen will be good. So oxygen will be in which color pipeline? Again, try to recall. Oxygen will be present in your white. Oxygen is important. That would be white. Air will be black, and vacuum, just extend the V into Y, that would be your yellow color. Okay, and nitrous oxide will be blue. Okay, nitrous oxide will be blue. Very good, guys. Now, which is the best way to recognize the cylinder? How do we recognize the cylinder? What is the best way? And this was the question they have asked you in NEET PG examination. Try to answer. Color coding, pin index. Sometimes our day is very bad, right? Just like that we are having the wrong answers. Okay, So the answer will be label, guys. Label is the most important thing. That is why they have asked this question. Label is the most important thing to recognize the cylinder. Apart from that, other things will be coming secondary. Okay, understand this. Okay, this is the previous year question asked in recent examination. Okay, which is the cylinder associated with black body and white shoulder? Try to answer this. No problem, guys. If you are making mistakes over here, there is no problem. Don't make these mistakes in your examination. In this particular PDF we are having approximately 70 to 80 questions from your examinations. Okay, every question is here. What is the cylinder associated with a black body and white shoulder? Why you are answering D, Antonox? That would be black body, white shoulder. Simple, guys. Oxygen cylinder. Okay, oxygen cylinder. The color of nitrous oxide cylinder, that would be, we have already discussed this. Third time we are discussing. Multiple times they have asked this question. Okay, so this is your completely blue. Okay, now we will be discussing about the circuits. Okay, circuits, we have discussed about the anesthesia machine. Try to recall what we are studying. We have our patient is lying down on the OT table. We have connected our patient to the anesthesia machine, right? Now for connection, for we have studied about anesthesia machine. For connecting our patient to the anesthesia machine to patient, what we need some circuit, right? We need some circuit. So what are the different types of circuits that we are having? We are having, first one, we are having open circuit, we are having semi closed circuit, and we are having closed circuit. Okay, closed circuit will be circle system that is present in your OT, okay. Open circuit, directly we are pouring the anesthesia on the skin or on the nose itself, right? For example, have you have seen about in the movies, like for example someone is putting chloroform, okay, and like we used to do with the ether itself. But open circuits are not nowadays preferred, not in the use. Okay, semi closed are the ones which are in the use, and we are having the another name of these semi-closed circuits, that is known as Mapleson circuit. Okay, they are basically portable circuits. Mapelsons are portable circuits, whereas closed circuits are non-portable. They are present in your OT itself, right? They are present in your OT itself. Okay, now try to see. Important one that we have to study is about the semi-closed circuit. In semi-closed itself, the question that they have asked you is from the semi-closed. Okay, is from the semi-closed. Thank you guys. Okay, semi-closed circuit. Be with me till the end of the session. This one will be clear to you. Okay, first one is your A, second one is your B, third one is your C, D, E and F. We are having 6 types of circuit. Okay, so just remember A4 alone. If someone is alone, he will be breathing spontaneously. First of all, try to understand what is the meaning of spontaneous breathing and what is the meaning of controlled breathing. Okay, spontaneous, that means the patient himself can inspire, himself can expire. That is the meaning of spontaneous breathing. Okay, if the person is alone, he will be eating Maggie. Okay, so that is also known as McGill's circuit. Okay, another name for this one is modified Mapleson A. This is also known as Lex circuit or coaxial Mapleson circuit. I will be telling you how to identify. Okay, so first of all, just see, A is for the spontaneous ventilation, another name is McGill circuit. B and C are not in the use. D is known as dependent circuit. So whenever something is dependent, that means D for dependent, you can remember D for dependent, that is for the controlled ventilation. If the patient cannot breathe himself, we will be putting the patient onto Mapleson D. Another name will be Bain circuit, another name will be coaxial Mapleson D. Okay, so two important that we have to remember: Mapleson A, Mapleson D. Then we are having Mapleson E, that is known as Ayer's TPs. This is a useless circuit. And then someone has did the modification, and who has done the modification? That is your Jackson-Rees modification of IRTPs. Okay, Jackson-Rees has done what? He has put a single valve over here. He has put this balloon, right? He has put a balloon over here, and this is known as Jackson-Rees modification of IRS TPs. Okay, so if they are getting questions, if you are getting question based on the diagram, how you will solve these questions. Okay, so how you will solve these question based on the diagram? First of all, just remember what I am telling you. If this valve, try to look here, if this valve is near the patient end, okay, this is known as adjunct. Okay, this is known as adjunct. This is your Mapleson A. This is your Mapleson A. Okay, if fresh gas flow and APL will be together, that means just remember, if both of them are together, that would be Mapleson B. That would be Mapleson B. How to identify C? C will be having corrugations absent. Corrugations will be absent. Here you can see corrugations. Here you can see corrugations. In Mapleson C, there is no corrugations. So that is your Mapleson C. Okay. In Mapleson D, you will be having APL. I'm always talking about the APL. So APL is distant here. Okay. D for distant. If the APL is distant, that means the valve is distant. So this one is your Mapleson D. Next one is your Mapleson E. Mapleson E will not have balloon. Okay, E will not have balloon, and Mapleson F will be having balloon, but it will not have what? It will not have valve will be absent. Valve will be absent. Okay, so these are the 6 circuits that you have to remember. Try to recall again. A means adjunct. A means adjunct. That means APL valve will be near the patient end. Second is your B. B will be having both the things will be together. C will be having absent corrugation. D will be distant. That means APL is distant. E means what? There will be absence. There will be no, there will be exit will be free. Okay, there is no balloon. Okay, and that is your F. F will be having balloon, but there is no valve. Okay, now you can easily identify all the Mapleson circuits. Okay, so now we will be discussing about one by one how do you identify these circuits. Okay, how do you identify these circuits? Just try to look here. If you are seeing a single tube is present, that means it is a which circuit? It is a alone circuit. If you are finding both the tubes, if you are finding two tubes, look here, we are having two tubes here, that is your Mapleson D. That is your Mapleson D. Okay, so this is how you will be remembering. If it is a single tube circuit, you can see there is only single tube present, that is your Mapleson A. Okay, if two tubes are present, that is your Mapleson D. Mapleson D is also known as dependent circuit. Okay, dependent circuit. Okay, now I've already discussed with you that how you will use these circuits. Okay, so just remember the important points from this particular table, because this table is very, very important, guys. Okay, this table is important. So what are the important things that you have to see over here? Whenever I will talk in the terms of A will be alone. A will be alone, also known as spontaneous. A will be having Maggie. Okay, alone होगा तो क्या करेगा? The patient will be having, the person will be eating Maggie. Okay, this is also known as, the modification is also known as leg circuit, also known as coaxial Mapleson. Okay, second one we are having is D. Mapleson D is used for control ventilation. Okay, and it is also known as Bain circuit or coaxial Mapleson D. Okay, E will be useless. Okay, and F we are using, this is the circuit of choice in pediatric patients. Okay, this is the circuit of choice in pediatric patient. Anything is happening, the circuit of choice will be this particular circuit. Okay, this particular circuit, this is known as Jackson-Rees modification of IRS TPs. Okay, based on this they will be asking question. Try to solve multiple questions we are having. Try to solve this one. A 5-year-old child is spontaneously breathing and is going under minor elective surgical procedure. Which of the following circuit can be the circuit of choice here? Try to answer. Cypria, C, A. What would be your answer? Try to answer, guys. How many says A, B, C, D? So first of all, what we have remembered, we will be solving question based on this. Okay, so first of all, the patient is spontaneously breathing. Try to look for the keywords. The patient is spontaneously breathing. Okay, and is undergoing minor elective surgical procedure. Which of the following circuit can be the circuit of choice over here, right? So what you need to see, everyone is answering right? You guys are reading the question very nicely. Okay, so first of all you need to look here. This is all about the child. Okay, this is all about the child. Don't go for spontaneous any type of breathing in a child. Your answer will always be F. That is your circuit F. That is your Mapleson F. Okay, that is your Jackson Rees circuit. Okay, now try to solve this one. Very good, guys. Now try to solve this one. A 29-year-old patient presented in a surgical emergency with an acute infection and was posted for emergency surgery. An anesthetist decided to give him general anesthesia. Which of these Mapleson circuit is best for spontaneous ventilation in an adult patient? So these type of questions, they are doing a lot of try to look here, guys. Okay, so this type of question, these are long questions. Okay, in long questions, what you need to do, you need to look for the keywords. Okay, you need to look for the keywords. What is the keyword that is given here? Spontaneous ventilation in an adult patient. So try to look for the last line. When you look for the last line, you will be finding spontaneous ventilation in adult patient. Your answer would be, everyone saying A. Your answer would be A. Mapleson A. A for alone. Alone will be eating Maggie, what we have learned. Okay, alone circuit will be eating maybe Maggie. And how many tubes you will be finding over here? How many tubes you will be finding in this type of circuit? That is your single tube. Okay. Second one. Next one is your, a 4-year child comes to the emergency operation theater for the removal of aspirated foreign body. Okay, with the aid of rigid bronchoscopy. During the removal of the foreign body, spontaneous ventilation was maintained with a smaller sized ET tube. Which of the following is the ideal anesthetic circuit for this particular case? Right, now you guys are reading the question very nicely, but in examination you will be having a lot of anxiety, and due to anxiety, what will happen? You will be missing those keywords. Okay, so two keywords you have to remember here. First one is the child, and second one is spontaneous ventilation. Your answer will be Jackson-Rees circuit. Okay, try to solve this one. A 25-year-old patient was posted for exploratory laparotomy due to an abdominal injury. An anesthetist decided to give him controlled anesthesia. Which circuit is most effective for controlled ventilation? Your answer will be, your answer will be, answer will be D, guys. Answer will be D. Remember, guys, Mapleson D is the universal circuit. If we do not have Mapleson A, we can always use Mapleson D in the cases of spontaneous ventilation also. Okay, Mapleson D is known as universal circuit. Okay, try to solve this one. A 35-year-old female has undergone a radical hysterectomy. Under general anesthesia, an anesthetist attached to this patient the following breathing system. What is the name of this particular system, right? This is known as try to solve this one. This is Bain circuit, guys. Bain circuit. Magill circuit is type A. Bain is type B. Okay. When you are dependent on your Bain, you can remember you are dependent on your sister, right? That is your Bain. Okay. In Gujarati, that is Bain, right? So that is your Mapleson D. Mapleson D. Okay. So how you will identify this? It is having how many tubes? 2. Okay, it will be having double tubes. Okay, so that is your Bain circuit. That is your Bain circuit. Okay, so we are done with the circuit. Now we will be discussing about the drugs. Okay, now we have already connected our patient. Okay, so the patient is coming to you for some kind of surgery. What you have done? What you have done to your patient? Let's recap everything. What you have done to your patient? Your patient is coming for some kind of surgery. You have done the PAC. First of all, there will be PAC. You will be checking for Malampati grading. You will be checking for glottic opening. Then you will be giving the clearance to the patient. Some drugs that patient will be taking. Okay, after that, what will happen? The patient will be coming to you for surgery. So before surgery, what you will be doing, you will be giving some pre-operative medications that we have discussed. Then before performing surgery, you will be doing intubation to the patient. You will be using laryngoscope. You will be putting some devices, that is endotracheal tubes. You will be connecting that tube with the anesthesia machine. We have discussed anesthesia machine. It will be having three parts: high, intermediate, low pressure system. High we have seen that is your pin index system. Intermediate we have seen disc, and low pressure system will be having vaporizers. Now we have connected all the things together, right? Now we have already connected all the things together. We are having three types of circuit that we are using. One is open circuit, second one is semi-closed, third one is closed circuit. In the OT, we are using closed circuits for portable, for like the patient is going from one place to another place in a hospital itself. Then we are using semi-closed circuit. Okay, semi-closed, we have seen two things. One is spontaneous ventilation, another one is for controlled ventilation. That is Mapleson A and Mapleson D. For pediatric, any case, your answer would be Jackson-Rees modification. Jackson-Rees modification. Now, since we have already connected our patient, it's time to give the drug to the patient. Okay, so we are having three categories of drug, three types of anesthesia we are giving to the patient. First one is your general anesthesia, second one is your regional anesthesia, third one is your local anesthesia. Okay, in general anesthesia, guys, we are having two things. One is inhalational agent, second one is your IV agents. So what are the inhalational agent that I would be teaching you in the next things? That would be your first one is your halo, second one is your isos, third one is your sevoflurane, lastly we are having desflurane. We are having methoxyflurane and fluorine. Those are also there, but we don't use it nowadays. Okay, so the most important one we will be discussing, one is halothane, second one is iso, third one is sevo, fourth one is desflurane. In the IV part, we will be discussing about two things. We are having opioids. In the IV, we are having opioids, we are having non-opioids. Okay, general anesthesia means there is loss of sensation from the complete body. Okay, complete body will be anesthetized. Okay, so what are the opioids that we are using? We are using morphine, we are using drugs like morphine, we are using sufentanil, we are using remifentanil, alfentanil, sufentanil. Okay, we are also using remifentanil. So these are the opioids that we are using. Okay, non-opioid drugs that we are using are your propofol. Important one is propofol. Second one is your etomidate. Third one is your thiopentone. And fourth one is your ketamine. These are the important one that we need to remember. Okay, then we will be discussing about the regional anesthesia. Regional anesthesia will be having two things. One is we can use amides, second we can use esters. Okay, one we can use amides will be having 2I that I will be telling you. Okay, so amides will be what? Amides will be having your lignocaine. Write down, we are having lignocaine, we are having bupivacaine. Okay, I will be telling you important function about all of them. We are also having like dibucaine. Okay, esters will be drugs. Esters will be having cocaine, they will be having single I. We are having cocaine, procaine. Okay, we are having benzocaine, they will be having single I. Okay, once we are done with both the things, we will be discussing about the muscle relaxant. Muscle relaxant is a different property. Muscle has a particular property. That means when you are stimulating a muscle, it requires optimal stimulus. Optimal stimulus, if you are giving to a muscle, it will be contracting. Okay, so we are having two types of thing. One is depolarizing muscle relaxant, another one is non-depolarizing muscle relaxant. Okay, depolarizing means what? You are giving more than adequate stimulus. So what will happen? Muscle will get relaxed. Okay, I told you muscle will be working on an optimal stimulus. If you are giving more, depolarizing will be giving more stimulus. So what will happen? The muscle will not contract. Second one is your non-depolarizing muscle relaxant. Okay, non-depolarizing we are having like curonium, curares. Okay, so depolarizing muscle relaxant will be first, that is your succinylcholine. Just like acetylcholine, it is the brother of acetylcholine, that is your succinylcholine. Okay, non-depolarizing muscle relaxants are your curonium and your curares. Okay, your curare, your atracurium, cis atracurium. Okay. So these are the things that we will be discussing. So in our further discussion, what we are going to do, we are going to learn the things in this particular manner. Okay, we will be discussing about general anesthesia, then we will be discussing about regional and muscle relaxants. Okay, so first of all, I will be telling you important points, and then I will be asking you some questions. Okay, there are some one liners you have to answer in the last, so try to be attentive till the end of this class. Okay, so look here guys, first of all we are having is halothane. Halothane is contraindicated in which type of surgery guys? First thing, it is contraindicated in hepatic surgery. Why halothane is contraindicated in hepatic surgery? Sir, it will be causing a disease that is known as autoimmune hepatitis. That is the point you have to remember. I am just giving you the important point that you have to remember. So halothane will be causing hepatitis, and that is known as autoimmune hepatitis. Second thing, it is contraindicated in neurosurgery. Why? Because it will be increasing intracranial tension. Okay, it will be increasing intracranial tension. That is why we are avoiding this particular thing in hepatic surgery as well as neurosurgery. Okay, but it is an agent of choice in respiratory surgeries. It is an agent of choice in respiratory surgery because it is a very good bronchodilator. It is a very good bronchodilator. Okay, so we can use halothane. Three things you have to remember: hepatic surgery contraindicated because it can cause autoimmune hepatitis. Neurosurgery, it will be increasing tension. Third thing, respiratory, it will be a good bronchodilator. We can utilize that. Okay, second we are having is isoflurane. Remember, it is a irritant. It is a irritant, and it will be showing a particular phenomena that is known as coronary steal phenomena, also known as reverse Robin Hood phenomena. Okay, next we are having is sevoflurane. Sevoflurane is a nephrotoxic compound. Sevoflurane is a nephrotoxic compound. That is why we will be avoiding this particular thing in kidney surgeries. But it is having sweet smell, and it is a good bronchodilator. So sometimes this can be induction agent of choice. Induction agent of choice in children. So it is an induction agent of choice in children. So we can directly induce the patient with the help of this particular drug, right? That is your sevoflurane. Okay, next one we are having desflurane. Desflurane is again irritant to the respiratory system, and we can use this particular drug in obese patient because it has a good volume of distribution. Okay, it can distribute easily, so we can use it for the obese patient. Okay, so obese patient, and it is the maintenance agent of choice. Okay, so whenever we are inducing a patient on any drug, we can maintain that particular patient on desflurane. We cannot induce the patient on desflurane because it is irritant to your respiratory system. Okay, now try to solve this question. These are the important points about these things. Okay, now try to solve this question: what is the preferred method for inducing anesthesia through inhalation in children? Try to answer this one. Your answer will be inhalation, induction agent of choice, inducing agent of choice in children. That is your again SIVO, guys. SIVO will be having sweet smell. Just remember, SIVO will be having sweet smell. That is why it is the induction agent of choice. Okay, second, which of the following listed below can be utilized for the purpose of inducing anesthesia, sustaining it, and safely performing endotracheal intubation? Your answer will be again your answer will be sevoflurane, guys. Sevoflurane is good for maintenance, good for induction as well. Okay, so it can be utilized for the purpose of inducing, it can be utilized for the purpose of sustaining. Okay, so that is sevoflurane. Why it is utilizable? Because halothane we don't generally use, and second thing, desflurane and isoflurane are already irritants, so we cannot use desflurane, we cannot use isoflurane, right? So halothane and sevo will be the left one, and sevo will be having sweet smell. It will be having sweet smell, so we can use sevo. Okay, try to solve this one. Which of the following listed below is not employed for initiating anesthesia in pediatric children? These are all the questions. These are all the questions that has been asked in your examination. Now I really hope you are not going to make any of them wrong. Okay, so try to answer this one. Very good. Carpal tunnel. Nitrous oxide will be good smell. SIVO will be good smell. Halothane will be good smell. So your odd one out will be What would be your answer over here? Very good, guys. That is your desflurane, guys. Desflurane. Not employed. Try to read complete question. Which of the following below is not employed for initiating anesthesia in pediatric patient? Okay, we can use halothane, we can use CO, we can use nitrous oxide, but we cannot use desflurane. Desflurane is irritant, guys. Irritant. Alone, we are not using nitrous oxide, but we can use that. Okay, it will be having good smell. Okay, which inhalational agent is best suited for patient with compromised cardiac functioning? Compromised cardiac functioning. Here we can use isoflurane, we can also use desflurane, guys. Okay, because both of them are having rapid onset and rapid effect, rapid offset. Okay, both of them are having rapid onset and rapid offset, and both of them are cardiac stable. Okay, in the studies, we are finding that isoflurane is more stable as compared to desflurane, but in your books the answer is already desflurane that is given, right? So we can use any of them, right? Which anesthesia agent from the options provided is known to cause toxicity to the liver? Try to answer this one. These are all your previous year questions. I know you know all the answer. Halothane will be causing what? Autoimmune hepatitis. Halothane will be causing what? Autoimmune hepatitis. Okay, so that would be causing toxicity to the liver. Now we will be discussing about the IV anesthetic agents. Remember what we have seen? We are having two classes. One is opioids, another one is non-opioids. So opioids will be having first one, that is your morphine. Second one, remifentanil, sufentanil, alfentanil. Okay, so basically we are using these opioids for the analgesia purpose. Analgesia means what? They will be utilized for the pain killing purpose. They will be utilized generally for the pain killing purpose. They will be having a special property, that means they are cardiovascular stable. Opioids are cardiovascular stable, but remember guys, they are unstable for respiratory system. Okay, they are unstable for respiratory system. They will be causing what? They will be causing respiratory depression. Okay, they will be causing respiratory depression. Okay, so we cannot use these drugs for respiratory system. Okay, that is the first point. Okay, they can cause respiratory distress. Okay, second thing, we are having non-opioids. Non-opioids will be thiopentone, propofol, etomidate, and ketamine. We are having thiopentone, propofol, etomidate, and ketamine. Let's see one by one all the important points about all these things. Okay, let's see one by one. So first one, this one is your thiopentone. This one is your thiopentone. It is a yellow color powder. It is a type of barbiturate. We are having barbiturate, benzodiazepines and barbiturate. So it is a type of barbiturate. Okay, what it will do? It is like a yellow powder. Okay, and we are using this particular drug in narco analysis. What we are doing, we are injecting this particular drug. What will happen? The cognition of the patient will decrease. Okay, and whatever the patient know, he will just speak out. Okay, it will be generally decreasing the cognition of the patient, leading to whatever he know, he will be telling the truth. You must have seen these things in your movies, right? So that is the agent we are using for narco analysis. One more thing, that is your scopolamine we can also use. Okay, this is the fastest agent. This is the fastest agent we are having, that is your 11 to 14 second. That is one arm circulation will be good enough, right? It is contraindicated in two things. One is porphyria, second one is your bronchial asthma. It is contraindicated in two things. One is porphyria, second is bronchial asthma. They have already been asked. Okay, so important points I am marking, right? So they have already been asked. Okay, so this is about the thiopentone. Second one is your propofol. Very important, propofol. Multiple questions they have asked you, right? So it will be having, just remember X. It will be having egg lecithin, it will be having glycerol, it will be having soybean. EGS, just remember EGS. It will be having egg lecithin, glycerol, and soybean. Okay, it will be a milky white thing, and once you will be opening this propofol, you have to utilize on the same day itself. Okay, within 6 hours you have to utilize this particular thing. It is a milky white thing. Okay, it is agent of choice in malignant hyperthermia. We have already solved this question. It is having anti-emetic property. That means after surgery, the patient will be having good sensation. Okay, next thing, it is the agent of choice in daycare surgery. It will be utilized for neurosurgery, liver and kidney surgery, any kind of daycare surgery. Your answer would be this particular thing, that is your propofol. This particular thing, that is your propofol. Okay, it is contraindicated in one thing, and that is the question they have asked you. It is contraindicated in shock patient. कहाँ पर contraindicated होगा? It will be contraindicated in shock patient. Okay, third one that we are having is etomidate. Important point that you need to remember about etomidate, it is a milky white substance. This one is CVS stable. CVS is stable. Okay, it will be contraindicated in the patient of adrenal suppression. Adrenal suppression patients, it is contraindicated. That means those patients who are ill for such a long time. Okay, these patients, it is contraindicated. That is your etomidate. Simple thing you have to remember, it is CVS stable. Okay, lastly we are having is your ketamine. This is a best bronchodilator in the IV category. In the IV category, the best bronchodilator is your ketamine. Okay, this one is your sympathomimetic, sympathetic nervous system ki tarah it will be working. That means it will be having action like epinephrine, norepinephrine, right? It is a sympathomimetic thing. Okay, it is agent of choice in shock, because shock we are using adrenaline or what. Okay, it is a agent of choice in bronchial asthma, and it can be used as analgesia, and it will be providing dissociative anesthesia. That means the patient will be awake, he will be looking at all the things, he will be understanding all the things, but the patient will not be having pain. Okay, this patient will be having hallucinations as well. Okay, this particular thing is contraindicated in hypertension, because hypertension is already a sympathetic condition, right? Hypertension mein we cannot use this particular drug. Second thing, epilepsy, you will be having multiple contractions in the body. Epilepsy, the body will be already contracted. And third thing is your glaucoma. These are the three contraindications that we have to remember about ketamine. So thiopentone, let's revise everything again. Thiopentone is a barbiturate. Second one, it is a yellow powder. Okay, it is a drug of choice in narco analysis, contraindicated in porphyria and bronchial asthma. Okay, now try to solve the question. Okay, which of the following intravenous anesthetic agent does not result in myocardial depression? All of the following will be causing myocardial depression apart from one. Which one is the cardiostable that we have studied now? Which one is the cardiostable, Bacho? Very good. That is your etomidate. Here we have already seen only one which is cardiostable, that is your etomidate. Okay, etomidate. Which of the following agent does not cause pain when injected? Which one is not causing pain when injected? These are the questions they have asked you. So look here, the ketamine will not cause pain when injection. Okay, ketamine will be painless. Apart from that, all of them will be having painful condition, because they are having egg lecithin, glycerol, soya bean, yellow powder is there. Okay, this one is also milky white in color. This is your clear fluid. Okay, so ketamine will not be having pain. Apart from that, other will be having pain. Which of the following is an absolute contraindication to the use of morphine, guys? Which of the following is an absolute contraindication to the use of morphine? One more thing I want to add here. Look here. Absolute contraindication, if they are asking about, that is your head injury. Because in head injury, what will happen? There will be increase in intracranial pressure, right? And morphine will be doing more increase in ICP. Remember guys, bronchial asthma, the patient, it is a relative contraindication. It is a contraindication we are because we already know morphine will be causing respiratory depression, but it is a relative contraindication. If the patient is having bronchial asthma, we can sometimes use morphine as well, right? But in head injury patient, we cannot use morphine. This is what you have to remember, NEET PG question. Okay, for a patient with cardiac disease, which of the following induction agent would be the most suitable option? Try to answer. So they are asking question again and again all around these things. Okay, that is why I've kept all these things together. Okay, for a patient with cardiac disease, try to learn things. Okay, if there is a patient with cardiac disease, what would be the agent that we will be using? We already know which one is the cardiac stable. Cardiostable is, very good guys, cardiostable is etomidate. For daycare anesthesia, what is the preferred intravenous induction agent? Which one is the preferred one for daycare anesthesia? daycare anesthesia, then your answer would be, guys, very good. Your answer would be propofol. Propofol. Which inducing agent is most likely accountable for the patient's hallucination and vivid dreams during the recuperation phase following anesthesia? Then your answer will be very good, Cypria. That would be your ketamine. Remember, I told you ketamine will be causing dissociative anesthesia and it will be causing hallucination and vivid dreams. Okay, so we are done with IV agents also. So these are the important questions that has been asked from this particular thing. Okay, now we will be discussing about the local anesthesia. Okay, local anesthesia, what are the important questions they will be asking? First, it will be stop. What will happen? How they will be working? They will be stopping the transmission of impulses locally by blocking what? By blocking sodium channels. Okay, by blocking sodium channels. Okay, and they will be acting on which type of sodium channel? Open sodium channels. And whenever we are mixing a particular thing with adrenaline, it will be decreasing the toxicity. Why adrenaline? Adrenaline will be working on all the receptor. These are your alpha 1, alpha 2, beta 1, beta 2. Alpha 1 will be causing vasoconstriction. Alpha 2 not so much significant. Beta 1 ultimately causing vasoconstriction. Okay, and beta 2 will be bronchodilation, right? So that is the function. So vasoconstriction will be there, and that vasoconstriction, because of that vasoconstriction, what will happen? That drugs will not go into systemic circulation. To prevent systemic circulation toxicity, what we are doing? We are adding adrenaline to the local anesthetics. Okay, we are having two class of drugs. One is esters, another one is amides. Amide will be having I, so that will be having 2I, guys. Here you will be finding 2I. For example, we are having lignocaine, we are having prilocaine, we are having bupivacaine, we are having dubucaine. Okay, so these are the drugs which are amides. Okay, we are also having esters. Esters will be having single I. We are having cocaine, we are having procaine, we are having chlorprocaine. Okay, important thing you have to remember, look here, all the amides will be undergoing what kind of metabolism? That is your hepatic metabolism, whereas all esters are undergoing metabolism by pseudocholinesterase. But there is the exception. What is the exception? And it is the exception, that is why they are asking question, right? So cocaine will be undergoing what? Hepatic metabolism. Cocaine is the exception, which is coming from ester, but still this one is going under hepatic metabolism. Apart from that, all other esters will be having pseudocholinesterase, that is present in your plasma, that is present in your blood, right? Now we will be discussing important points about cocaine. Cocaine will be causing what? Cocaine will be a vasoconstrictor thing. Okay, it will be causing vasoconstriction. That is why in FMT also you studied, you will be having nasal septum. There will be perforation in the nasal septum because of that cocaine. Okay, so basically because of vasoconstriction, what will happen? There will be hypertension because of cocaine. There will be hypertension because of cocaine. Second question, that is which one is the shortest acting? Shortest acting will be chlorprocaine. Just remember, shortest acting will be chlorprocaine. Shortest acting will be chlorprocaine. Okay, next one, they are asking about longest acting. Longest acting will be dibucaine. Okay, and the safest, which one is the safest? That you already know, you will be utilizing somewhere in your life. That is your nothing but your lignocaine. Lignocaine is the safest one. Okay, and the question that they have asked you, all of them are questions. Okay, most cardiotoxic is bupivacaine is the most cardiotoxic. Okay, so these are the important things, important questions that they have asked you. Okay, nowadays they are asking question based on complication of local anesthesia. Okay, and complication is known as local anesthesia systemic toxicity. What are the symptoms you will be finding? You will be having CNS symptoms, you will be having CVS symptoms. Okay, CNS symptoms will be, you will be having tinnitus, and second thing, you will be having perioral numbness. Okay, in CVS symptoms, you will be having arrhythmias. Okay, and you will be having cardiac arrest. Cardiac arrest means everything will be stopped, and the drug of choice for cardiac arrest, please try to answer in the chat section. Okay, what is the treatment? Treatment will be 20%, very very important, multiple times asked question, 20% intralipid solution. First of all, we need to remove whatever we are giving. We need to stop the infusion, and then what we can do, we can give 20% intralipid emulsion. That is the treatment of choice for local anesthesia systemic toxicity. Last, okay. What are the uses of these things? We can use topical, like for example, we are having amla is eutectic mixture of local anesthesia. What we are doing, we are having lignocaine, we are also having prilocaine. इसके ऊपर question and they have asked the question, so what is the concentration will be in the ratio of 1:1. Okay, that means 2.5% will be lignocaine and 2.5% will be prilocaine that is added. Okay, so 2.5% lignocaine, 2.5% prilocaine will be added, and this is known as amla. How we will utilize this particular thing? Look here, we are having this type of topical patches of amla. We will be putting that patch on the skin itself, and then we will be removing it. After that, what will happen, there will be numbness in that particular area, and we can put catheter, or we can do we can put the cannulas as well, right? So that is how we are utilizing this thing. Okay, next we are having is regional anesthesia. What is infiltration? In infiltration, what we are doing, we are depositing the anesthesia around the nerve fiber. Okay, for example, I want to do a tooth extraction. Okay, I want to remove some molar tooth. What I will be doing, I will be putting all the anesthesia just around the nerve fiber, so that there will be locally, there will be stoppage of impulse, there will be pain killing property. Okay, so that is how we are utilizing this. Okay, so this is all about your local anesthesia. Okay, we can also use this particular thing in caudal anesthesia also. Okay, next we are having is regional anesthesia. Regional means particular region will be blocked. For example, we are having central neuraxial blockade, we are having peripheral neuraxial blockade. In central neuraxial blockade, guys, what you need to see, we need to discuss about two things. First one is your spinal, and second one is your epidural. Okay, first of all, you need to remember spinal anesthesia is for, as for spinal, it will be for short duration. It will be for like just 1 to 2 hours. If I need a block for 1 to 2 hours, I would be using spinal anesthesia. Second one is your epidural. Epidural is for long term procedure. Okay, for example, like 7 to 8 hours. Okay, so that is the first difference that you need to remember. In spinal anesthesia, I would be putting my drug into the CSF. In the CSF, it is a one shot technique, less toxicity will be there, and it is a fast technique. Okay, second thing, in epidural, the drug will be present in your epidural space. इसके ऊपर क्वेश्चन आता है, they will be asking question based on location. Okay, I will be telling you how to identify the location in the next slide. Okay, so it is a continuous procedure, there will be more toxicity, and it is a slow process. Now you need to remember about the needle. They will be asking question on the basis of needle. How you will identify, sir? You will be identifying on the basis of needle. So if you are finding these types of marking, look here very carefully. If there is some kind of marking, if there is some kind of wings present, okay, if there is marking, if there is wings present, that is a which needle? That is a 2He needle. That is a 2He needle, guys. This is a 2He needle. Okay, and 2He needle we are using for what? Epidural anesthesia. We are using for epidural anesthesia. In a spinal anesthesia, we are using spinal needles. These needles will not have any kind of marking, and they are not having any kind of wings. Okay, we are not having any kind of marking as well as wings. Okay, we are having different kind of needles. We are having dura cutting, we are having Quincase, we are having Whitcare, we are having Sproties. Okay, we are having these different kind of needles which are present. Okay, so we will be having a side effect, that is post-dural puncture headache. Okay, so to prevent that, we are having these types of spinal needles. Okay, now they will be asking the most important question from this particular slide, multiple times asked question, guys. You cannot afford to miss this question. Okay, so first of all, what is the route, how we are putting drug, and when we and where we are putting the drug, right? So starting it off with the skin, we are entering from the skin. The first layer that we are piercing is your subcutaneous fascia. First layer will be subcutaneous fascia, then there will be supraspinous ligament. This is above, that is known as supraspinous ligament above. Okay, second one is your intraspinous ligament. This is your interspinous or intraspinous ligament, that is in between. Okay, and then there will be ligamentum flavum. Then there will be this particular structure, that is ligamentum flavum, okay, and then there will be depth. Okay, that is your durameter. Then there will be arachnoid, and then there will be pyometer. Before pia there will be subarachnoid. Below the arachnoid there will be a space that is known as subarachnoid space, right? This is how you will always remember, right? Pyometer will be there, right? Before pyometer and between subarachnoid there will be CSF. There will be CSF. Okay, now in spinal anesthesia I've told you it is a single shot technique. So what we will be doing in spinal anesthesia, the needle we will be using is spinal needle. Okay, it will not be having wings, it will not be having markings. Okay, so we will be piercing skin, then we will be piercing subcutaneous fascia, then we will be piercing, above will be supra spinous ligament above the spine. Okay, intraspinous, that is between the spine, this is your spine, so that would be your intraspinous, and then there will be ligamentum flavum, then there will be durameter, that is the outermost layer, dura will be dur. Okay, and then there will be arachnoid, and below arachnoid will be subarachnoid, and below subarachnoid will be pyometer. This is the pathway, okay, for the spinal one. Okay, for epidural one the same pathway will be there, but we will be stopping above the dura. We will be injecting our drug above the dura, and this is known as epidural space. Okay, so this is how we are giving epidural anesthesia we are using in labor also. Okay, so let's see what are the complications that we have to remember over here. Okay, what are the complications? Understood, guys? So we will be having first complication, that is hypotension. How you will be treating hypotension? You can give drugs like phenylephrine is a alpha 1 agonist. Okay, phenylephrine alpha 1 agonist means ultimately, sir, it will be causing what? Vasoconstriction. When it will be causing vasoconstriction, that will lead to treatment of hypotension. Second, bradycardia. Always remember bradycardia, the drug of choice will be atropine. Okay, bradycardia with AV block, the drug of choice will be atropine. Okay, for urinary retention we can use neostigmine. Neostigmine is the drug that we are using for urinary retention. Okay, what are the contraindications when we are not going inside for spinal or epidural anesthesia? First thing, if there is site infection, if there is any kind of infection on the site, what will happen? Due to needle, what will happen? The infection will go deeper, right? Second is your increase in intracranial tension, and if the patient is having some kind of cardiac disease, because it will be causing some complications with the heart. So if the patient is already having some kind of cardiac disease, we would be avoiding this type of anesthesia. Okay, labor analgesia. For labor pain killing properties, we are using this type of catheter, that is known as epidural catheter. In epidural catheter, first of all we are using local anesthesia, and then we will be using opioids for pain killing property, or also known as analgesia. Okay, so this is the gold standard for labor analgesia. Okay, what is the needle that is shown below? Try to answer, guys. This is the question they have asked you. What is the needle that is shown below? How you will identify? Remember what I have told you. You are seeing some kind of markings is present. Okay, second thing, you are seeing some kind of wings are present. If markings is present, wings are present, that would be your wonderful, guys, that would be your Tooheys needle. Okay, try to solve this one. Which local anesthesia among the following leads to increase in blood pressure? These are the types of question they will be asking in your examination. Okay, so you have to answer. We already know cocaine will be causing vasoconstriction, and cocaine will be increasing in blood pressure. Okay, cocaine will be increasing in blood pressure. Bupivacaine is the cardiotoxic one. Okay, it will be increasing blood pressure. A patient presented with headache, what are the symptoms they have given? Headache, vomiting, fever, and meningitis was suspected in the patient. While performing a lumbar puncture, which is the last structure you will be piercing just before entering the lumbar cistern? Try to answer this one. Before entering into lumbar cistern, what is the last structure that you will be piercing? You want to do lumbar puncture to get what? To get cerebrospinal fluid, and to get cerebrospinal fluid, which is the last layer that you will be piercing. Remember, guys, I have told you the innermost layer will be pyometer. Above pyometer will be arachnoid, and between them will be subarachnoid. Okay, and remember what I have told you. what I've told you, just look here, let me show you. So that is your subarachnoid and this is your pia mater. Between pia mater and subarachnoid there will be CSF. So what will be the last structure that we are piercing? Last structure that we are piercing will be arachnoid, and this is the last exam question. This is the last exam question that they have asked you. Ligamentum flavum, that is very above. Okay, we are going from skin, supraspinous, we are having interspinous, then there will be ligamentum flavum, so it will be automatically cutted. Dura mater, it is also automatically cutted because that is used for epidural anesthesia, right? So pia mater is already not in the option, so your answer would be arachnoid membrane. Okay, arachnoid membrane. Now try to solve this one. What would be the most appropriate approach to manage a young in managing a young male patient who received regional block using 0.25 bupivacaine for a minor surgical procedure but experienced sudden unresponsiveness and unrecordable pulse shortly? Unrecordable pulse is there. Try to answer. What is this happening here? We are using this. We are using what? Bupivacaine. Remember what I've told you. Bupivacaine is the cardiotoxic. And can you see unrecordable pulse and there will be cardiac arrest type of situation? Okay, first of all, we need to remove that drug, and second thing that we need to do, we need to put we need to give CPR. CPR, why we are giving CPR? Because there is cardiac arrest. In cardiac arrest, the first thing that we can do is CPR. Then we will be giving adrenaline. Adrenaline is the drug of choice. We can also add on it with the atropine as well, because atropine will be dealing with bradycardia with AV block. Okay, and adrenaline will be working on all the receptors, so we can give that drug, and CPR is the first line. And second thing, the drug of choice will be 20% intralipid solution. Okay, now next thing is your, how do local anesthetics exert their mechanism of action? Try to answer this one. They will be blocking what? Sodium channel, potassium channel, or what? So suppose this is a basically how local anesthesia is working. Remember, let me teach you. This is your cell body, this is a neuron, this is your cell body, this is your axon, this is your synapse, right? Now information is going in from that neuron itself, right? Now what they are doing here, we are having sodium channel, here we are having sodium channel, right? So what they will do, they will just block the sodium channel. They will just block the open type of sodium channel. They will just block the open type of sodium channel. Okay, so what will happen if the sodium channels are blocked? That means there will be no action potential. Action potential will be stopped because sodium channels are already blocked. If action potential is stopped, what will happen? Is there any transmission of impulse? No sir, there will be no transmission of impulse, so it will be no movement. There will be no movement of the impulse, right? Next thing, what is the likely diagnosis for a patient who received a 20% injection of during resuscitation? So what can be the cause here? What can be the cause over here? Try to answer. The cause will be 20% intralipid. They have already given in the question. These are exact question of your recall exact questions. So basically they are repeated ones. Okay, but try to solve all of them. Okay, because anesthesia approximately 80 to 100 questions are there. Okay, so what would be your answer? Your answer will be local anesthesia. Local anesthesia toxicity. That would be your local anesthesia toxicity. Okay. During epidural anesthesia, which of the following structures are not penetrated? Epidural anesthesia. Which of the following structures is not penetrated? This is the question they have asked approximately 5 to 6 times. Okay, try to answer this one. Very good. Very good, guys. Wonderful. Okay, so how we are going? We are piercing first of all skin, then we are opening supraspinous ligament. Supraspinous spine is there. Okay, so first one is your supraspinous, then there will be interspinous, and then there will be ligamentum flavum. Okay, so lastly, epidural means what? Epidural means above the dura. So the drug will be injected above the dura. Your answer will be dura, right? Which type of anesthesia is most suitable for preeclampsia? Which type of anesthesia is more suited for preeclampsia, guys? Try to answer. A, spinal. Remember, guys, spinal Spinal cannot be the answer. Spinal we are giving for short period of time. Okay, spinal, remember, S for spinal, spinal for the short period of time, right? Pre-eclampsia or eclampsia we will be seeing in which patient? They are generally pregnant patients. Okay, they are generally pregnant mothers. Just remember, there is increased risk of airway edema. Okay, there is high risk of airway edema, so we cannot give general anesthesia here. Okay, so here our answer will be epidural. Remember, we have already seen epidural is the agent of choice. Epidural is the anesthesia of choice. Along with that, via epidural I can again give analgesia also, right? So that is the gold standard. Okay, that is we have already discussed. Okay, how do local anesthetics works? That is the again repeat question. Next one, what is the preferred anesthesia for dental surgery performed in a daycare setting? Daycare setting mein what is the anesthesia of choice? In daycare setting, what is the anesthesia of choice? Very good, guys. That is your infiltration. Wonderful, wonderful. General anesthesia, we don't use general anesthesia because in your dental surgeries, need not to have general anesthesia. Spinal, epidural, they require expertise. Okay, they require expertise. We don't have that. Okay, in dental clinics. Okay, so that is your infiltration. What they will be doing, they will be putting all the drugs like all the drugs that we are using like lignocaine, okay, xylocaine. They will be putting the drugs around the nerve fiber of the root for root canal also, and that would be causing infiltration anesthesia. Okay, in epidural anesthesia, which of the following layer is least likely to be punctured during the procedure? Try to answer this one. Epidural. So in epidural, we are not going to deal with the arachnoid. We will be dealing supraspinous, after skin, supraspinous. There will be intraspinous, infraspinous, ligamentum flavum, but not arachnoid matter. Okay, so this is how the questions are being asked. These type of question they are asking. Now we will be discussing about the muscle relaxants. Okay, I have told you muscle has a specific property. What is that specific property? That means it will be contracting over a particular stimulus. Okay, over a optimal stimulus, over a optimal stimulus. The muscle will be contracting over a optimal stimulus. Okay, so we are having two types of muscle relaxant. Muscle relaxant is for the relaxation of muscle. What will happen if muscle is not relaxed? The patient will throw his hand, or maybe he will kick you on the face, right? So that is why we need muscle relaxation during surgery. Okay, not because of that. Okay, but we need muscle relaxation. Okay, so we are having two types of thing. One is depolarizing, which was second one is non-depolarizing. Depolarizing means what? I am giving some drug which is just like acetylcholine which is coming from the nerves. It will be causing contraction of the muscle, that is neuromuscular, that is present in your neuromuscular junction, right? So what I will be giving, I will be giving a drug which is similar to acetylcholine, that is your succinylcholine, and this is the shortest acting muscle relaxant. Remember guys, this is the shortest acting muscle relaxant, but this one is contraindicated in nerve muscle injuries. Okay, this one is contraindicated in nerve muscle injuries. What are the things that can happen over here? We are having hyperthermia, bradycardia. Okay, hyperthermia can happen, bradycardia can happen, and these things you must have already seen in the malignant hyperthermia can also happen over here. Okay, it will be having fast metabolism. What are the uses will be for rapid sequence of induction. We can give the patient succinylcholine. Second, ECT, remember guys, now the drug has changed. For ECT we are using methotrexate. Remember, methotrexate is the drug that we are using nowadays, that is electroconvulsive therapy we will be studying in psychiatry. Okay, for difficult airway also we can use that is grade 3 Mallam patti, or that is grade 3 or 4 in Cormac-Lehan also. Okay, so when the anesthesiologist will write grade 3, the doctor will be automatically sensitized to the fact that the patient can be having difficult intubation. Okay, non-depolarizing, we are having two classes. One is aminosteroids, second one is benzyl isoquinones. Okay, aminosteroids, amino will be having no, so they will be having no release of histamine. No, just remember, amino will be no, so there will be no histamine release. Second thing, if there is no histamine release, they are cardiovascular stable. First of all, tell me what is the function of histamine. Two function will be there of histamine. Okay, tell me in the chat box. we are having it is CVS stable. Third thing, it is used in liver and kidney also. It is liver disease and kidney disease, we can also use that. Okay, agent of choice in bronchial asthma. Histamine has two things. It can cause bronchoconstriction, it can cause vasodilation. Whenever a vessel get dilated, what will happen? Something will come out, right? That is why this is basically a autoquit. So whenever you will be having some insect bite, what will happen? At local place, you will be having some kind of inflammation, right? What is that? Because there is vessel is getting dilated and something is coming out, that is giving you red appearance. Okay, second function, it will be causing bronchoconstriction. That is why it is called bronchoconstriction. So these amino steroids will not have histamine. That is why they are the agent of choice in bronchial asthma patient. We cannot use benzyl isoquinolones because they are histamine releasers, and I have told you histamine will cause what? Bronchoconstriction. Second thing, they are CVS unstable and they can cause bronchospasm. Okay, two things you have to remember. Amino steroids, no, just remember no, that means they will be not releasing histamine. No histamine means CVS stable. Okay, and they can be used in other things also. Okay, two things we have to remember. Apart from that, two important things that we are having is, one is cis atracurium, another one is atracurium. Okay, cis atracurium and atracurium, two important things. They are undergoing a specific type of elimination that is known as half man's elimination. Which is basically the drug will be metabolized automatically. That is spontaneous metabolism will be there. Spontaneous metabolism of the drug will be there. Okay, and this one particularly is safe in kidney and liver disease. This one particularly is safe in kidney and liver disease. So it does not need any kidney or liver for metabolism. It will be going under spontaneous metabolism, safe in kidney and liver disease. Okay, so there are some reversal agents that we need to study. So we are having two reversal agents. One is we are having for the depolarizing, and for the non-depolarizing we are having these reversal agents. So first one is your neostigmine plus atropine. These are the indirect agent that we are using for a long time. Okay, we are giving neostigmine and we are also giving atropine. Second one that we are having, that is your sugamadex is a direct inhibitor of rocuronium and vicuronium. Okay, and next one we are having is calabidone, that is a direct inhibitor for all non-depolarizing agent. Okay, all non-depolarizing agent, that is a new drug, that is calabidone. Okay, next try to answer which is the fastest clinically available non-depolarizing muscle neuromuscular blocker. Fastest, which one is the fastest? Try to answer, guys. Which one is the fastest one? Out of these four, which one is the fastest one? Just remember, guys, that is your rocuronium. Just remember, rho is like rocket. It is rocket fast. Okay, and we are using rocuronium for like modified RSI also. Modified RSI, rapid sequence of induction. Okay, modified RSI, and that would be taking approximately 1 to 2 minutes. Okay, next, in the provided image, the patient's neuromuscular monitoring following anesthesia is depicted. Which nerve is most frequently utilized for this particular purpose? This is the question they have asked you. Anaphylactic shock, no, anaphylactic shock is a different entity. In anaphylactic shock, the drug of choice again will be adrenaline, because it will be working on again all the receptors of alpha 1, alpha 2, beta 1, beta 2. Okay, we need bronchodilation as well in the anaphylactic shock. Okay, in the provided image, the patient's neuromuscular monitoring is given. What is the nerve they are asking? The nerve will be ulnar nerve. Guys. Okay, ulnar nerve. And the type of response that we are giving, that is your train of 4 response. The type of response that we are giving is train of 4 response. Okay, next, a patient who received a supraclavicular brachial plexus block with 0.5% of bupivacaine develops hypotension and arrhythmias. We already know it as a cardiotoxic. Okay, what is the first line of treatment for this particular situation? First line of treatment, again this is the same question they are repeating, so your answer will be 20% intralipid solution, because this is a local anesthesia systemic toxicity. This is a local anesthesia systemic toxicity, guys. Okay, next, a patient with high bilirubin levels and high serum creatinine is planned for a surgery. What is the muscle relaxant of choice in this particular patient? And there is a patient who is planned for some kind of surgery. What is the muscle relaxant of choice? At least you are clear with what is muscle relaxant, what is local anesthesia, right? What is general, what is inhalational agents, right? Try to answer this one. From all of them, the best one is mivacurium. Very good, Vicky. That would be mivacurium, because this one is the shortest acting, guys. This one is the shortest acting, guys. Shortest acting. This one is the shortest acting. Okay. Next, try to answer. These are the specific agents of choice. I have incorporated whatever we have studied till now. I have made a table for that. Okay, so we will be revising everything very fastly. Okay, so from IV agents, first thing, from IV agents we are discussing IV agent of choice in heart disease. That is your IV agent of choice. We have seen thiopentane, we have seen like etomidate, we have seen ketamine, propofol. The best for cardiac disease, heart disease, your answer would always be etomidate. They will simply ask you simple questions. Okay, so your answer will be etomidate. Second, for asthma, if they ask in the terms of IV agent, the best will be ketamine. The best will be ketamine. Okay, for shock, try to answer this one. For shock, what is the best one? For shock, what is the best one? Okay, in daycare surgery, the agent of choice will be propofol. For neurosurgery, again the agent of choice will be propofol. Neurosurgery, also the agent of choice will be propofol. Try to answer. For shock patients, IV anesthetic agent of choice will be. Till now I'm discussing about the inhalational agents. Okay, till now I have discussed, let me discuss about the inhalational agent. For heart disease, we can use des equal to iso. We can use desflurane as well as isoflurane. Okay, iso will be showing a better advancement nowadays. Okay, so des and iso. Okay, second, for asthma, what is the best inhalational agent that we are using for asthma? Remember guys, halothane and CO. We can use halo and CO. Halo is a bronchodilator, first slide we have seen, and sevoflurane will be having good smell, so we can use both of them, right? So for shock patient, that is ketamine. Remember guys, we have seen ketamine will be working as a sympathomimetic agent. Okay, it will be having sympathetic activity that is utilizable for the shock patient, right? But you have to remember one more thing. What is the one that cannot be used in the shock? What is the agent of choice? My question is, what is the agent of choice that cannot be used in the shock? Try to answer. Okay, till then look here. For the shock patient, the agent of choice in inhalational will be des more than iso. For daycare surgery, we will be using desflurane. For neurosurgery, we will be using isoflurane. Okay, let me talk about muscle relaxant. For heart disease, we can use coroniums. No wale use millennium. We have to utilize those who are not releasing the histamine. Okay, for heart disease we can use vicuronium. We can also use rocuronium. Okay, second, for asthma we can use again coronium, because histamine will be there, so we need not to utilize anything from histamine. Okay, for shock patient we can again use pancuronium. For daycare surgery, that is the shortest acting, that is your mivacurium. For neurosurgery, all of them are good enough. All of them are good enough. Very good, Vicky. For shock, the contraindicated will be propofol. Remember, there is one contraindication for propofol, that is we cannot use propofol in the shock patients. Okay, in the shock patients. Now we will be discussing about the oxygen delivery system. There is some multiple question from these systems. Okay, so we are having two types of devices. One is low flow devices, another one is high flow devices. Okay, दो चीजें you have to remember, two things you have to remember. One is about the FiO2. What is FiO2? Try to understand the simple meaning. FiO2 is the fraction of inhaled oxygen. Fraction of inhaled oxygen. What does this mean, sir? In the environment, you are having 21% of the oxygen. So whatever air you are inspiring, how much amount of air? If you are inspiring 100% of the air, out of that 21% will be oxygen. That is known as FiO2. FiO2 means what? There will be, that is 0.21 will be the FiO2. This is how we can write. Okay, in the environment, whatever oxygen I am inspiring, out of that 0.21 will be oxygen, and this is known as fraction of inspired oxygen, fraction of inhaled oxygen. Okay, this is what is FiO2. Second thing we have to remember is about the flow meters. Flow meters, you must have seen flow meters in your intermediate system. I've told you about the intermediate system. Okay, in intermediate system, I've told you about various pipelines that are present in your hospital, right? Near the pipeline, near the bed of the patient, what is there? This type of structure you have seen. These are known as flow meters, and it will be having some water or some substance here that would be doing what? Humidification of the air. Here you will be having 55 psi. Okay, 55 to 60 psi. That is the part of intermediate system. Okay, so what you can do, you can just on or off the gases from here, and you can give it to directly to the patient. Okay, so this is about the flow meter. Now let's see, we are having two types of flow devices. One is low flow device, another one is high flow device. Low flow device, we are having nasal cannula, simple face mask. Okay, face mask with reservoir. These are your low flow devices. High flow, we are having, first one is your venturi mask, second one is your nebulizer, third one is your high flow nasal cannula, and lastly we are having is ambu bag. Lastly we are having is ambu bag. Okay, let's see one by one. First one, this is your nasal cannula. We are utilizing this particular thing in mild hypoxemia. Mild hypoxemia, there will be, we can use nasal cannula. What is the flow rate? We can use flow rate of 2 to 6 liter per minute. And what is the FiO2? It can give, out of complete air that it would be giving, it can give 24 to 45% of oxygen. Okay, it can give 24 to 45% of oxygen out of whatever air it is giving, right? That is FiO2. Understood? Now second is your simple face mask. Simple face mask, or this one is your Hudson mask. What is the flow rate? Again 6 to 10 liters, and FiO2 will be 35 to 60%. You can remember. Okay, this one is, again, this is your face mask with reservoir. This was the image they have asked you in the last examination. Okay, we are having two types of face masks. One is rebreathable, another one is non-rebreathable. Non-rebreathable will be giving 60 to 80% of the FiO2, and rebreathable will be giving 60 to 70% of the FiO2. But the difference will be here. Difference is the flow rate. The flow rate will be more for non-rebreathable mask. The flow rate will be more. Okay, these are the low flow nasal cannula devices. Okay, these are the low flow devices. Okay, now we will be discussing about the high flow. The first you have to remember is the venturi mask. Venturi mask is this. This is a high flow device, and there will be fixed FiO2. That is your 100%. Whenever you will see these valves, okay, whenever you will see these type of structures, that is your venturi mask. They have asked question based on this. They can change their FiO2 as well, right? That is your venturi mask. Okay, second one is on nebulizer. Nebulizer is also a high flow device. What we will do, we will put the drugs like salbutamol, ipratropium bromide. We are putting those drugs in the form of capsule, and what it will do, it will make it in the form of a breathable thing, right? So that is your nebulizer. This one is your high flow nasal cannula device. That is the question they have asked you. They have given you this particular image, and this is also the image that you have to remember. It will be having multiple things. It will be having this humidifier. Okay, it will be having humidifier, so you will be getting heated and humidified gas. Okay, flow rate can be up to 60 liter, and it can give FiO2 21 to 100%. 21 to 100%. Okay, 21 to 100%. Okay, heated and humidified gas will be there. Lastly, we are having bag and valve ventilation. So this is a type of mechanical ventilation that we are pressing the valve. We are pressing this particular bag. Okay, FiO2 can be 0.21 to 100%. If we are connecting this particular thing, to the cylinder, we can change the FiO2 as well, right? So this is what you have to remember. Which device in conventional oxygen therapy will provide the highest FiO2? Try to solve this one. Highest FiO2 will be given by highest and humidified and heated gas will be given by which of them? Venturi? No. Don't talk about rest. We will be finishing in next 10 to 15 minutes. Okay, don't worry about rest. We are almost done. Yes, very good. That is your high flow nasal cannula. That is your high flow nasal cannula device. This one is the high flow device. Okay, that is giving you humidified and heated gases. Okay, try to solve this one. Which of the following airway devices helps in maintaining the FiO2 24 to 60%? Okay, irrespective of the patient's breathing effort. Irrespective of the patient's breathing effort. So fixed FiO2 we can put in which type of thing? That is your Venturi mask. These are your low flow devices. These are your low flow devices. The high flow only here will be Venturi mask. But at least you have to remember this is from the INI. So INI they can ask directly, but you have to remember at least some of them, right? So that is your Venturi mask. Okay. Identify the equipment that is shown in the image below. Try to answer this one. Try to answer this one. Is that a mechanical ventilator, infusion pump, or HFNC? Very good. That is a HFNC. That is a high flow nasal cannula device. That is a high flow nasal cannula device. And this one is also that has been asked in your FMG examination. Identify the mask in the image used for the patient with COVID-19 infection. Okay, what is that? Try to answer this one. Very good, Karpal. Very good, Anuj. That would be your non-rebreathing mask. That would be your non-rebreathing mask. This is your non-rebreathing mask, guys. Okay, Hudson will be different. Okay, you can see the image. Hudson will be different. This is your Hudson. Okay, this is your non-rebreathable mask. Okay, this is your non-rebreathable mask. Okay, now we will be discussing about the last chapter, that is about the fluids. We are having different kinds of fluids. We are having crystalloid, we are having colloid. Okay, for example, you must have seen in your hospital, you will be finding 0.9% NaCl. That is the sodium saline, right? That is the sodium saline. Why there is 0.9%? Because that is isotonic to the plasma. That is isotonic to the plasma. We are having two things. One is crystalloid, another one is colloid. Okay, crystalloid, just remember the name. What is a crystalloid? That is a, for example, normosol. This is your plasma light, plasma light. Okay, colloid will be having these things, like for example complete blood product, or maybe we are having dextran. We are having this one is your albumin. This one is your albumin. Can anyone tell me the function of albumin, guys? Can anyone tell me the function of albumin? This is your normal saline. This is your normal saline. This is your ringer lactate. Ringer lactate. These are all your crystalloids. And here we are having is colloid. Okay. Here we are having is colloid. Try to answer the function of albumin. Albumin is a plasma protein. What would be the function? Till then, look here. We are having crystalloid. We are having the function will be edema. No. Keep your concepts clear. Blood in vascular composition. It is a protein. It is a protein. It is a plasma protein that is present in your blood vessel. Okay, it is present in your blood vessel and it is making your blood thick. It is making your blood thick. Just remember like that. What will happen if there is loss of albumin? What will happen? Your blood will be thin. Your blood will be thin, and what will happen? The water will come out. The water will come out and it will get accumulated in the body. Okay, so water will come out and accumulated in the body. Wherever it will get accumulated, we will call it differently. Like for example, the water in the abdominal cavity, we call it ascites. So whenever there is albumin loss means proteinuria. Albumin is formed in the liver, right? If there is any kind of liver pathology, like for example cirrhosis, what will happen? There will be ascites, right? Ascites, why, sir? The function will be, it will be maintaining, terminology will be, it will be maintaining BCOP, that is blood colloidal oncotic pressure, right? Whenever there is decrease in the level of albumin, what will happen? The water will definitely come out. Okay, it is making the water thick. Now what is happening? Just like a sugar syrup, just like the sugar syrup, and we are having sugar molecules in the syrup, right? So it is not coming out, but when sugar molecules are lost, what will happen? Only water will be left, and water can come out, right? So that is how we have to remember. Okay, so we are having two things. One is crystalloid, another one is colloid. So let me give you an example. We are having a road traffic accident. The patient is having blood loss. the patient is having blood loss. So for example, let's say 2 liter blood is lost. Now how much amount of colloid and how much amount of crystalloid you will be giving to the particular patient? Okay, so how much amount of colloid or crystalloid you can give to this particular patient? Just remember, whenever we are giving crystalloid, we are giving in the ratio of 3:1. 3:1, that means we need to give 6 liter. If 2 liter of blood is lost, we need to give 6 liter of colloid or 6 liter of crystalloid. Crystalloid are like your NS, your RL, your plasmalyte, your normosol. We need to give that 6 liter. Okay, but when we are giving colloid, for example, we are giving PRBC, we are giving packed red blood cells. Then how much we will be giving? We will be giving in the ratio of 1:1. That means 1 liter of blood is lost. That means we can give 1 liter of colloid. Okay, so what are the colloids? We are having blood, we are having albumin, starch, and dextran. These are the example you have to remember. Okay, these are the examples that you should be remembering. Okay, now try to solve this particular question. A 56-year-old male was brought unconscious by his friend to the emergency department. He has reported chest pain about an hour ago. Along the way, he lost his consciousness. Okay, he is a known patient of ischemic heart disease and diabetes mellitus. He has features of consistency with cardiac arrest. Which would be the fluid of choice in this particular situation? What is the fluid of choice that you will be utilizing in this particular situation? Try to answer one. What is the fluid of choice you will be using here? What is the fluid of choice you will be using here? Very good. And Vicky, Piyush. Very good, Anuj. Okay, so that is your normal saline, guys. Normal saline we will be using. We will not be using dextrose. We will be using normal saline. Along with that, cardiac arrest is there. What is the drug of choice? I've told you. We will be using adrenaline. Why? It will be working on alpha 1, alpha 2, beta 1, beta 2, ultimately leading to increase in vasoconstriction. Beta 1 will be increasing what? Let me recap for you just before examination. It will be having two receptors. One is present on your heart. Beta 1 is present in your heart. What it will be doing? It will be activating AC node, that would be increasing in heart rate. It will be activating AV node, that would be increasing in conduction. It will be activating your muscles, that will be leading to increase in contraction. Apart from that, beta 1 will be present in your kidney, and from there it will be releasing renin, and renin will be doing what? Ultimately it will be activating RAS system, and ultimately it will be activating vasoconstriction. Here what is happening? Cardiac arrest. Cardiac arrest means heart is not working, right? Heart is stopped completely, and beta 2 will be utilized for bronchodilation. Okay, so this is how you are treating the particular thing. One of you have already asked about the anaphylactic shock also. So the drug of choice for anaphylactic shock is also same, and the reason is also same. Okay, next one. A 30-year-old male present to the emergency department with physical examination findings suggestive of severe dehydration. First thing, severe dehydration. He is commenced on intravenous fluid at a rate of 1800 per ml, 1800 ml per hour. What cannula will provide the highest dehydration rate in this particular patient? Okay, they want to know the color of the cannula. Okay, so how many says yellow, green, pink, blue? What is your answer? Try to answer. Or let me teach you. The answer will be gray, guys. The answer will be gray. How to remember? Look here. We are having the complete mnemonic, that is, try to look here. We are having this thing. If you can remember this thing, you have already remembered this thing, I know. Okay, but I will be telling you about the flow rate of particular cannula. You can also remember the mnemonic. What is the mnemonic? Oh great God, please bless your people. Okay, that is the mnemonic. Okay, so we are having this 14 gauge, 16 gauge, 18, 20, 22, 24, and 26 gauge. Okay, gauge means what? The narrowest is the gauge. For example, we are having 14, that means it will be having biggest diameter. It will be having biggest diameter. So all of them, which one will be having the biggest diameter? So orange will be having the biggest diameter. Apart from orange, we can also use green. Okay, what is the flow rate? Flow rate will be approximately 250 to 300 ml. Here 150 to 250 ml, that is what we are utilizing for the trauma cases. Okay, trauma, we will be putting two large bore IV cannulas, that is your orange or gray. Okay, then what we will be doing, we will be infusing the fluid, right? We will be infusing the fluid. Okay, for adult, for normal situation, we are using green and pink. We are using green and pink. Green will be having 100 to 120 ml per minute, and pink will be having 55 to 80 ml per minute. Okay, then we are having pediatric patient. Pediatric patient, we will be using there will be blue and yellow. We will be using blue and yellow. And lastly, we are having premature baby, or we are having old people. We will be using purple one. Purple one will be having the smallest diameter and largest number, that is 26 gauge. Okay, that is 26 gauge. Okay, so the mnemonic is, oh great God, please bless your people. Okay, please bless your people. Okay, so that is the mnemonic. Okay, now we will be discussing the last slide that we have to do is about the important one liners. Whatever you have studied, try to answer as fast as you can in the chat section. First of all, that is your, which agent not used in patient with egg allergy? Of the following agent will not use in the egg allergy? What is the answer will be? Very good, Vicky. That would be your propofol. That would be your propofol. Try to answer for the second one. Should not be used if open for more than 6 hours. These are all questions. I have put them in the form of one-liners. Try to answer. Should not be used if open for more than 6 hours. Again, your answer will be very good. That is your propofol. Most common used in daycare surgery. Again, your answer will be propofol. Okay. Which one causes adrenal suppression? Adrenal suppression patient. Which one we will not give? Now try to answer. Not propofol. Answer for question number 4. Which causes adrenal suppression? Adrenal suppression, guys. Try to answer this one. Someone please try to answer. That is your etomidate. Etomidate, guys. Etomidate. I am talking about IV first. Okay, most cardiostable IV agent that we have seen. Again, your answer will be very good. That is etomidate. Okay, so adrenal suppression patient, we are not using etomidate. Adrenal suppression patient, we are not using etomidate. Okay, long term, if someone is ill for such a long period of time, we will be avoiding etomidate. Okay, most cardiostable IV agent will be your etomidate. Next, causes hallucination and delirium. Which one is causing hallucination and delirium? IV. Your answer will be ketamine, guys. Your answer will be ketamine. Most painful on IV injection. Which one is most painful on IV injection? Most painful on IV injection. That was the previous year question they have asked you. Try to answer. Very good. That is your propofol. Wonderful, guys. Okay. Best IV bronchodilator. Best IV bronchodilator. If they ask you, your answer will be ketamine, guys. Ketamine. Remember, we have seen 4: thiopentone, propofol, etomidate, and ketamine. Ketamine will be the best bronchodilator. Okay, it is sympathomimetic. We will be using in the shock itself, right? Second gas effect or diffusion hypoxia, we will be seeing it with the nitrous oxide, because we will be mixing nitrous oxide with other gases also, right? So that would be nitrous oxide. Which one is preferred for induction in children? Okay, try to answer. Which one is preferred for induction in children? That is inhalational. Which one is inhalational present for IV, present for induction in children? That is your sevoflurane. Okay, preferred for induction in asthma. Asthma patient, we can use halothane. We can also use halothane. We can also use sevoflurane. Okay, halothane or sevoflurane. Preferred for induction in neurocardiac or liver surgeries. Which one we are using from inhalational? Which one we are using preferred for induction in neurocardiac and liver surgeries? Neurosurgery, cardiac surgery, liver surgery. We can use isoflurane, guys. Very good, isoflurane. Okay, which one is preferred for renal and liver failure? Which one is present in liver and renal failure? Try to answer. That is your desflurane. Desflurane also for cardiac diseases also. Okay, in cardiac diseases also we can use desflurane and isoflurane. Okay, shortest acting depolarizing neuromuscular blocker. What is that? Shortest acting depolarizing neuromuscular blocker. Depolarizing, we have only seen one, that is your succinylcholine. That is your succinylcholine. It can cause malignant hyperthermia. It can cause malignant hyperthermia. Shortest acting non-depolarizing neuromuscular blocker. Very good. That is your mevacurium, guys. Mevacurium. We have already discussed that. Okay. Fastest acting non-depolarizing would be rocuronium. Rocket, just like a rocket. That is your rocuronium. And lastly, we are having Hoffman elimination is seen with, that is seen with, sorry, that is seen with atracurium and cis atracurium, guys. Atracurium and cis atracurium. Okay, we all have to do hard work, Kavya. We all have to do hard work, and this is what we are going to do, right? So thank you so much, guys, for all the patience. Okay, and these are my Instagram and Telegram. If you want to connect with me, you can definitely join me. I would be sharing the PDF. Okay, let's revise. First of all, let's revise what we have seen. Just looking at the recap, just doing a recap what I have taught you. Okay, in the 3 hours, what we have done. Introduction, I've told you about some scientists that are coming in your examination. Then we have discussed about different types of anesthesia, like general anesthesia, regional anesthesia, local anesthesia, infiltration anesthesia. Okay, whenever a patient is coming for surgery, we will be sending our patient to anesthesia department for pre-anesthetic checkup. We will be looking, most importantly, airway. That is your, how you will be looking for airway. You will be looking for Malampati grading. That is very important. They will be asking question based on that. Okay, then we have studied about intubation. Then we have seen different kind of monitors that we are having in the department, in the hospital, in the OT itself, right? We are having different kind of things. Then we have studied about the anesthesia machine. What are the different parts of anesthesia machine? We are having high pressure system, intermediate pressure system, low pressure system. Okay, we have to remember pin index, we have to remember diameter, and then we have to remember about the vaporizers. Okay, then we have discussed about the different kind of circuits that we are having. We are having Mapleson circuits, semi-closed and closed circuits. Okay, Maplesons are important. A, B, C, D, E, F are the important ones. Okay, then we have seen the different type of agent that are asked in your examination. Apart from that, we have seen the oxygen therapy. Okay, and certain fluids. Now the only thing that you have to do, is to solve some question from one thing, that is emergency medicine. Okay, you have to solve some question from emergency medicine, that is BLS and SCLS part. Okay, BLS and SCLS, you have to solve some question because they are asking question repeatedly every year. Okay, that is the part we have left, so you will be seeing that. Okay, I will be sharing PDF here also, and I will be sharing PDF to the Dr. Bhanu group also. Okay, so thank you. If you are having any kind of constructive feedback, you can always do let us know. Okay, thank you so much, guys, for the patience, and we will be meeting for further sessions also. Thank you, guys.